Now we're moving into treatment interventions, which starts with treatment planning. Overall, what you need to know is that treatment planning is an ongoing piece, and there's 4 different things to think about, which is how you formulate your case, what you want to get, what the client wants to get out of treatment, what's the way to get there, so the interventions, and then how you're going to monitor progress. The first step of treatment planning is developing the case formulation. Generally, there's basic things you want to know, like what's the problem, diagnosis, why do you think it is, what are people expecting, and one thing that's very important is to integrate diversity into the conceptualization. So that's can be aspects of identity, conceptualization, cultural features of the relationship, and just a general cultural assessment. You want to be able to set goals and objectives. Goals are broad, comprehensive, and long-term, whereas objectives are specific, short-term, and measurable. So it would be something like increase interpersonal functioning might be a goal. An objective might be, going out, re-engaging with, your best friend or something. And just know about diagnosis, goal setting, know what are the evidence-based treatments that are going to be used, know what the commonly used interventions are for different psychiatric diagnoses, know when you need to make referrals, what kinds of referrals you need to make, and what's the termination process in general with treatment. Be able to include the family and monitor effectiveness. And it's important if you want to do evidence-based practice to prioritize different interventions with different clients. When you're taking the test, go through the questions, and so if you have a vignette, you're going to highlight their age, their symptoms, and their diagnosis. You want to highlight the severity and the chronicity, and you want to highlight for yourself what did the patient say and what did others say. After you have that information, walk yourself through 4 things before you read the answers, and you can do this pretty quickly. What are medications and adjunct referrals that I would make here if I was to do that? So medication, adjunct referrals. 2, what would the goals of treatment be if you were seeing this client? And 3, to meet those goals, given the vignette information, what are the most appropriate interventions? And 4, what treatment outcome are then you hoping to have? So name those things. So see if you can name to yourself right now what those 4 would be. So medications and referrals, 2, goals, 3, interventions, and 4, outcome. So what are the basic steps of treating a client? You want to obtain their informed consent, build your alliance with them, get them motivated, educate them regarding the diagnosis they have, and then you're going to set the treatment options and goals together, which you will monitor with the client. So that means that you need to know about treatment planning, which is the setting of goals and tasks that take into account the consideration of the unique patient, the nature of the problems and concern, the likely prognosis, and expected benefits of treatments, as well as available resources. When you engage in your treatment planning, you of course have to understand your case first. Then you identify your goals and objectives, like we've said. So these are the 2 pieces, case formulation, goals, objectives, and then you move to the generic treatment planning process. So what is that process? The next steps after formulation and goals objectives are to choose your intervention strategies and figure out how you're going to monitor treatment. It's really that simple. Formulate, set goals, choose strategy, and methods for monitoring. The implementation is a single phase during which a relatively circumscribed set of problems are addressed. So what are your goals and objectives generally going to be? Generally, you want to improve their functioning and decrease their symptoms. So when you read a vignette, think to yourself, what does improved functioning look like? So you formulated, you know what the diagnosis is, what the symptoms are, and what are these main symptoms? What do I want to see a decrease in? So if the answer is something like, be happier, that's really not getting at a very clinical picture. And when you select the strategies, as we know, you want to consider both the client characteristics and treatment factors. So what are some of those factors that you want to look at? The orientation, there's all sorts of different matches between therapist and client, and therapist orientation and diagnosis. What are the empirically supported treatments? What is the level of care and mode of treatment that they need? What format are you going to do it in? And really, they want to make sure you know that you're thinking about monitoring and terminating with clients as well. The generic treatment plan. So that would mean that there's an early stage, right? So you have a client come in, maybe it's their first time in therapy, maybe not, but if they're first coming to see you, there might be more of a crisis. So you address the immediate concerns. Once you kind of address those, that's when you go into the early stage of a treatment where you're doing assessment and goal setting and some of those initial interventions. Then you get into middle and late and termination, where you kind of progress at deeper levels and you get to the point where you have really improved functioning and decreased symptoms, and make sure to work with your client for strategies to maintain the gains that they had in therapy after termination. So we need to think about and really think thoroughly about how we are going to implement and monitor our effectiveness. So thinking what you want to assess for. So are you going to assess for depression with your ADHD client? Maybe if they have depression as well, but that's probably not going to be what you should prioritize. How are you going to use the data? What referrals are you going to make? And how do you prepare for termination? So monitoring the effectiveness can also help you know when you need to make referrals and when you need to terminate. They do not call it mental retardation anymore because of the stigma that became connected with that. But you do need to include a specifier in terms of the severity. So working with intellectual disability, first you want to know about assessment. So when we think through treatment, we want to think about assessments and interventions and monitoring. So in terms of assessments, adaptive behavior skills like the Vineland are important, semi-structured interviews, behavior checklists, and educational tests. And with treatment, there's 5 main areas or 5 things to note. So education and training to help increase skills to live productive and independent lives, behavioral interventions, and then you can just do psychotherapy and family interventions. And for adults, you want to focus on day treatment programs, behavioral interventions, and also giving caregivers support. Usually community-based instruction, community resources for the family can be helpful here. And behavioral interventions are aimed at reducing aggressive, self-stimulating, and self-injurious behavior. Functional behavior assessments can help with this piece. So what is a learning disorder? There's 3 subtypes in reading, writing, and arithmetic. Pretty easy to remember, reading, written, mathematics. And it is marked by difficulties related to academic skills, as indicated by the presence of at least one symptom that lasts for at least 6 months despite provision of appropriate interventions. Usually you will see that on a particular area, the patient lies 1.5 standard deviations below the mean. In terms of learning disorder treatment, you're going to focus on 3 different pieces: instructional, behavioral, and family. So the instructional piece would be designed to remediate underlying deficits and improve cognitive skills, and also just help give strategies to compensate for any associated problems. Specifically, phonological awareness training, cognitive strategy training, and direct instruction are used. Further behavioral interventions and family interventions are helpful. The behavioral is to alleviate coexisting problems, like behavioral contracting, and family is really to help the parents modify their expectations, and that helps enable the patient to succeed more. Phonological awareness, so this is a specific instructional intervention. It's a broad skill that includes identifying, manipulating units of oral language, parts such as words, syllables, and onsets and rhymes. Children who have phonological awareness are able to identify and make oral rhymes, can clap out the number of syllables in a word, and can recognize words with the same initial sounds like money and mother. Cognitive strategy training, also used to treat learning disorders, can be applied in terms of self-instruction, self-questioning, self-monitoring, and memory strategies. However, there are several limitations that have been identified, but these cognitive strategies help people with learning disorders learn to think through and kind of not compensate exactly, but have tools to deal with any sort of deficits. And also just to know that treatment is very multidisciplinary. So first, let's just say the basic summary of autism. How many diagnostic criteria sets are there? There are 2. What are they? Social and repetitive in terms of patterns of behavior, and there must be impairment. This is developmental, so it must be early onset, early developmental period. Usually you can see by 12 months. There are often intellectual impairments, language abnormalities, uneven profile of cognitive abilities to go with, and 3 levels of care: support, substantial, and very substantial. So we're going to talk about the best treatment as well. And just to summarize, educational and vocational interventions are helpful. In particular, TEACH, which is directed specifically, will help with the communication, social, and coping skills. For adolescents and adults, vocational training and placement can be helpful. We also have behavioral interventions, and that's expected. Applied behavior analysis and pivotal response training are the 2 main ones. Applied behavior analysis kind of tries to reduce the self-injurious and other behaviors like that and promote desirable ones. It incorporates a functional behavioral assessment. Pivotal response is an application of it, and it's supposed to really target motivation and responsivity. Psychotherapy can be helpful, but in particular directive types to treat the comorbid conditions like depression and OCD that might come along and help with social skills. Given that there's often a lot of support needed, it's really important to include the parent and family and refer to community services. And finally, medication is not really effective for the core symptoms of autism, but it can be useful for treating depression, anxiety, and other symptoms that might be contributing to distress. What's the key? Here's the key, and to remember, you need deficits in 2 core domains. So when you think autism, think deficits in 2 core domains. And those 2 domains are the social and the repetitive. Understanding autism in the brain, it's been linked to unusually rapid head growth during the first year of life and structural brain abnormalities, particularly in the amygdala and cerebellum. Serotonin, dopamine, and other neurotransmitter abnormalities are present. And now, what are the 3 levels? So this is another thing that's important to remember about autism. There's requiring support, substantial, and very substantial. So 3 different levels. Always important on the HPPP is what the prognosis of disorders are. So it's important to know that the later the onset, the more able to communicate by 5, and the higher the IQ, above 70, which is often the cutoff for intellectual disability, means a better prognosis. So what about treatment? Often there is a team approach. And because there can be a lot of actually somatic things that come along with this and gastrointestinal problems, you have usually professionals from a lot of different domains supporting the individual, and professionals that help address different aspects of the disorder, like speech, being able to work, being able to deal with the body, and then nutrition has, there's certainly some different diets that have been posited as more helpful. When you use reinforcement to increase a response, it's necessary to wait for the response to actually happen to emit it. Now, if you are an abstract thinking adult, shaping doesn't come into play as much, because you can say, hey, touch your finger to your nose, and you can understand that cognitively and do it. But for something that either rarely never occurs, or if you have an animal or a child, shaping can be used. That means that you reinforce successive approximations to this desired behavior. So you get reinforcement as you come closer and closer to what you're actually supposed to be doing. So here's an example, and this is actually teaching mute children with autism or schizophrenia to speak, because you can see there's a little bit of a change in cognition from an abstract thinking adult. Training begins with having the child imitate the trainer's voice to encourage. To encourage this, the child's reinforced simply by looking at the trainer's mouth. But when the child accomplished this task, the trainer modeled the sound and reinforced the child only when he or she made a vocalization. Eventually, the child's reinforced only for imitating the particular sound. And then once the sound is mastered, the trainer introduces a new sound, and this procedure was continued until the child's able to say words and speak in simple sentences. With a pup, that could look like anytime they get close to their ball, then they get a treat. Then it can be, once they've really mastered that, it's when they touch the ball with their nose, they get a treat. And when they've mastered that, it's when they pick it up and bring it to you. So it progressively. So chaining seems similar, but it is actually different than shaping. Skinner described this as three-term contingency, the sequence of discriminative stimulus, behavior, consequence. He says this is what accounts for actually the acquisition of most complex behaviors, including behavior chains, which consist of a number of distinct responses. So making a cake would be an example, or eating a plate of food, let's say. First, if you're a kid eating a plate of food, this is actually not, there's actually a number of steps to it. First, you have to pick up your fork. Next, you have to learn to scoop some of that food onto your fork, get it on there. You need to learn how to get that fork to your mouth. You need to learn to chew your food. You need to swallow. So some of those are pretty automatic. A cake is an example that is a little bit more complex. But the establishment of both of these behaviors are referred to as chaining. You really get your big reinforcer, such as eating that food, it going into your tummy, or getting to eat your cake at the end of the chain. And chaining can happen forward or backward. So you can start with the first component, like teaching the kid how to hold a fork or a spoon. But you can also use the reverse order. And in this example, it's a little bit harder, but you could think you put the food in the kid's mouth first. Then maybe you have the spoon is already in their mouth and you teach them to hold it. So you could go backwards or forwards. It's sometimes confused with shaping, and that's because they both have to do with establishing complex behaviors. But only the final behaviors of interest in shaping. So I want the dog to be able to bring me that ball. But yeah, I don't need her to be able to be near a ball. I don't need all of that kind of stuff. But in chaining, every step of that is important. So the pup getting the ball might be a behavior chain, but teaching her the word ball is shaping. Interventions incorporate a variety of strategies, including parent management training, special education, training in self-care and social interactions, vocation training, and placement using sheltered workshops and supported employment. Not listed here, but shaping and discrimination training are the behavioral techniques that were originally used by Lovaas in the 1960s, and these are the two techniques that you'll often see being used to improve communication skills. But there's also a lot of interventions that have been developed to really try to help these individuals be able to function normally and live happy lives. applied behavior analysis is one model for working with autism. Here's some requirements, the diagnostic criteria. The onset is prior to age 12. There need to be 6 symptoms of either inattention and or hyperactivity, and it needs to be present in 2 settings. Those are the 3 essential things. 6 symptoms, onset prior to 12, present in 2 settings. So we'll do a brief overview of ADHD treatment and then talk a little bit more about each piece. But there are 4 components to treatment. Not necessarily all are used, but 4 main ones that are used. And what are they? So pharmacotherapy, behavioral interventions, neurofeedback, and parent education training. Typically, you would just think combination of pharmacotherapy and psychosocial interventions when you think about the treatment of ADHD. Stimulants, methylphenidate tends to help, about 85%. Kids need to go on drug holidays because it suppresses growth. Behavioral interventions include contingency management, timeout, response clause, self-instruction, so they learn to talk themselves through things, self-evaluation, reinforcement, and control. They've also found neurofeedback can be helpful. And finally, helping parents develop specific skills that will help the kid with ADHD, like consistent rules, structured environment, and routines, and just generally giving them behavior management training themselves. To overview some of the treatments, behavioral, parent training, classroom management, peer interventions, and then, of course, there is the self-instruction therapy that's really big in terms of what the kid does with themselves. And it's important to refer to a psychiatrist for medical evaluation in this case. Always refer for the psychiatrist eval because it's been found that therapy alone really has limited effectiveness without the medication. Functional behavior analysis. These are interventions to behavior change that result, function-based interventions are the result of a functional behavior analysis. And these are basically conducted to determine, all right, some kid is hitting the wall in class. You are really wanting to look closer, like they're doing this undesirable thing. We wanted to substitute something more desirable, but you have to know what they're getting out of that. Are they getting approval from their peers? Are they getting attention from the teacher? Are they getting attention from their parents when they go home? So to do that, you might have observation, indirect or direct. You can have interviews and just any sorts of data that can give you information about the behavior and what the antecedents and consequences of it are. The ultimate goal is to decrease or eliminate undesirable and increase something alternative. So it's not just extinguishing a fear response with PTSD. It's really having very specified and alternative behavior that's desired. So with PTSD, it really could be, you could think of it as the alternative behavior is relaxation. So it is possible to think of it that way. But let's say with dogs, and the bell, with Pavlov's experiments, that the bell no longer creates it. That's not a functional behavior analysis. Functional behavior analysis, you also want to increase something positive because there's something not positive happening. So school psychologists might do that if there's a lot of issues with a particular student and talk to the student, talk to their teachers, go watch the class. And maybe they find out, hey, when he's doing something really a boring task, he's doing that to avoid working on the boring thing. So how could you intervene then? Well, maybe you can modify their assignments, give them more of a choice, give them a way to complete them that's going to help them to be more interested, and reinforce them for staying on task so they're not, so that the not having to do it was reinforcing them before, but maybe now they get cookies when they do their task, or whatever, probably not cookies in that case. So then the psychologist is going to evaluate the effectiveness using a single subject design to compare their frequency of on-task behaviors during baseline and treatment phases. The stimulants are used to treat ADHD primarily, although there's other things included on this list. Just make sure to know methylphenidates, Ritalin, and pemolines Cylert. Those are the most important. And what do? They make norepinephrine and dopamine more accessible, and that's the main cause of action. It can cause restlessness, and if you use too much for too long, it can cause psychosis. The side effects can be psychosis and can even look like schizophrenia. Withdrawal can cause agitation and hallucinations if there's a lot of use. And finally, stimulant drug holidays are really important because they can suppress growth in kids, and since a lot of kids take them, it's important that they can get a break. Contingency contracts. Application of reinforcement to naturalistic environment addresses problematic interactions and negotiate contracts. So what does that all mean? This is an application of contingency management that involves a formal written agreement between two or more people. So it could be the therapist and the client. It also could be teacher and students, etc. And you clearly define the behaviors that are to be modified and the rewards and punishments that will follow performance of them. So behavior change may be required by one or all parties to the contract. So let's give an example. If you have a therapist and client, then you'd require behavior change really by the client only. But if you have a contract between two spouses, then both people need to be making changes. According to Stewart and Lott, there are 5 elements necessary that this is going to be effective contract. Okay, first, explicit definitions of what each party is going to receive as a result of meeting responsibilities. Second, there should be sanctions that are clear if you don't meet the contract's terms. Third, behaviors need to be something that can be monitored. So be nice. You really need to operationalize what that means to be nice. So if it's complimenting 5 times a day, then that's something you can monitor. Fourth, the contract should define bonuses for consistent compliance with the terms of the contract. So if it's meditation, let's say you and your spouse agree that you're both going to meditate every day. If you meditate 5 days in a row, there's a bonus for having done so consistently. And the 5th is a record-keeping system to keep giving feedback to both parties about the frequency of behaviors and also so you can actually deliver the appropriate reinforcers. They're most effective when the person whose behavior is to be modified is actively participating in the development of the contract, because if this is getting handed to you by your teacher, that there's going to be more resistance. They're not fully on board. So there might be some good to it, but in general it's not completely helpful. Finally, let's talk about social skills training. Social skills training is used to improve communication, assertiveness, problem solving, all sorts of things that have to do with being socially adaptive. And this is a type of behavior therapy. And it's different from, it's not just operant though, it's classical, operant, and social. So it's really kind of coming at things from all angles to focus on better social skills. So that might include modeling, coaching, rehearsal, feedback, reinforcement, assignments, all sorts of techniques. And the idea is that it has to do with using these techniques to develop social skills. We know that people are getting less natural life training being behind the computer with Facebook, especially kids who maybe didn't grow up and have that socialization, and now they're behind the screen and maybe skills are lagging, but they're there. So kids especially might really need a lot more informal social skills training, if not social. This can help with schizophrenia, conduct problems, depression in all ages, and is really great when incorporated into a multimodal treatment. Self-reinforcement. Self-reinforcement is when you are administering the reinforcement to yourself. So this is something kids do for sure, but um, I think it especially brings up the image of adults who are trying to do weight loss or trying to lose weight, and they monitor themselves using records. There's apps on the phone now, and they start to also control their environment stimulus that they encounter to narrow the range of responses. So, two self-management procedures is just self-monitoring and stimulus control. Those are the two pieces to really know. Self-monitoring is what you usually do initially, and this is done with CBT a lot. You're recording things, getting information about the nature and magnitude of the behavior, and that also can help you develop what your treatment is going to be before you kind of move on to stimulus control and all of that kind of stuff. Stimulus control basically means that your behavior is under stimulus control when doing it is contingent on the presence of something else. So, cigarette smoking is contingent or controlled by things like drinking coffee, talking with friends, being alone, or having a pack of cigarettes. So when you want to use a stimulus control technique, you're altering your associations between the stimulus and the behavior. So narrowing is restricting the target behavior to a limited set of stimuli. So you can only smoke at 5 p.m. after work. That's not a great one because usually people who are smoking are trying to get rid of it altogether. But let's say with trying to lose weight, you only eat at meal times. You're not snacking and running into the kitchen and putting your hand in the bag of chips all the time. Cue strengthening. That's when you link a behavior to specific environmental conditions. Eating means sitting at the table. Studying, if you want to increase something like studying, then you cue strengthen. So when you go to your desk in the office, you study. So cue strengthening is more about increasing this particular behavior. Narrowing is usually restricting the target behavior to a limited set of stimuli. And fading consists of changing the stimulus conditions associated with the behavior. So this might be when a cat is trying to chew on your hand, you put a cat toy in their mouth. And this could also work if you have fetish objects. Give them something more appropriate. So Meichenbaum and cognitive behavior modification. Two programs associated with Meichenbaum's CBM are self-instructional training and stress inoculation training. Meichenbaum's approach tends to focus on self-statements, or the verbalizations that clients make to themselves. Like Beck, his approach emphasizes collaboration in a Socratic style of questioning. The interventions described below are going to be okay, so we're staying with Meichenbaum actually, and we're going to start with his self-instructional training. Meichenbaum and Goodman in 1971 originally used self-instructional training to help impulsive and hyperactive children perform academic and other tasks more successfully by teaching them to interpolate adaptive, self-controlling thoughts between a stimulus situation and the response to that situation. Self-instructional training, or SIT, incorporates the work of Vygotsky and Luria, who propose that true voluntary behavior does not occur until there's a shift from external to internal language control, as well as Bandura's work on observational learning. And there are 5 steps of the therapy. Cognitive modeling. The client observes a model perform the task while the model makes self-statements aloud. Self-statements include questions about the nature of the task, answer to those questions, specific instructions on how to do the task, and self-reinforcement. Second, cognitive participant modeling. The client performs the task as the model verbalizes the instruction. So you could also call that therapist verbalization. Overt self-instruction, or patient verbalization. The client performs the task while instructing him or herself out loud. fading overt self-instruction, or a patient silently talks through task. The client whispers instructions while carrying out the task. And finally, covert self-instruction, or independent task performance. The client performs the task while saying the instructions covertly. There's a slight parallel here with protocol analysis. Protocol analysis is a procedure that's used when a person is learning a task and is asked to describe aloud the steps being taken to solve the task. Protocol analysis is used to gain access to people's problem-solving strategies. So let's talk briefly about neurofeedback. In theory, kids can learn to keep their brain active while concentrating or performing by using biofeedback sensors as guides. During a therapy session, you use monitors and you can see what is helping your brain the most. So you can then use those strategies to help focus better. There has been some research that showed it improves. Parent management training, PMT, also known as behavioral parent training, BPT, is a family of treatment programs that aims to change parenting behaviors, help parents learn to use positive reinforcement methods to deal with behavioral problems. Moving into Tourette's disorder, let's just start with the summary of it. The diagnostic criteria here is one or more vocal tics and multiple motor tics. The symptoms need to persist over a year, and the onset needs to be before 18. OCD and school problems are often comorbid, and the tics may appear at the same or different times and wax and wane in frequency. Generally, you will see these tics do decline over time. You can specify whether it's a persistent or provisional if it's been less than a year. The best treatment for Tourette's overall is going to be pharmacotherapy, antipsychotic haloperidol, and comprehensive behavioral treatment, which includes habit reversal training, relaxation, and psychoeducation. Tourette's disorder is characterized by the presence of at least one vocal tic and multiple motor tics that may appear simultaneously or at different times. They may wax and wane in frequency, but they have persisted for more than 1 year, and it began prior to 18 years. For many individuals, the frequency, severity, and disruptiveness declines in adolescent or adulthood. There are associated symptoms of Tourette's, and most commonly, those are obsessions and compulsions. The rate of OCD is higher not only for those with Tourette's, but also for their biological relatives. Hyperactivity, impulsivity, and distractibility are also common and have been identified as a cause of the high rate of school problems that are exhibited by children with this disorder. So what's the etiology of Tourette's? Well, it's been linked to elevated levels of dopamine and supersensitivity of dopamine receptors in the caudate nucleus. So how do you treat it? It usually involves pharmacotherapy and the antipsychotic drugs haloperidol and pimozide. That's been studied most extensively, and they've been found to be effective in about 80% of cases, actually. A drawback of their use is the potential for negative side effects, and many patients find those intolerable. In addition, an SSRI is usually useful for alleviating the OCD symptoms that accompany the disorder. Note that because psychostimulant drugs have been found to increase tics in some individuals, the hyperactivity and attention that often accompany Tourette's is treated instead with clonidine, which is usually for hypertension, or desipramine, which is an antidepressant. Finally, comprehensive behavioral treatment for tics, CBIT, is an evidence-based treatment for children and adults with Tourette's and incorporates habit reversal training, relaxation training, and psychoeducation. So a little bit more about Tourette's. Just knowing that it's one or more vocal tics, multiple motor tics, persist over a year before 18, that the treatment is the antipsychotic, and also just no psychostimulants for ADHD can increase tics, and the comprehensive behavioral treatment. That's the overview again. Habit reversal training is what is that? It's a combination of awareness training, competing response training, and social support. So if the old behavior was automatic movement toward the itching area and then scratching it, 2 parts, then the new behavior would be squeeze your fist for 30 seconds and then pinch or press a nail into the part that itches. So you're giving a different potential response. You're increasing awareness of what's happening. It's multi-component, and it was developed to address a lot of repetitive behaviors, and it can be incorporated with all sorts of things. Actually, it's made up of 5 things specifically: awareness, competing response, contingency management, relaxation, and generalization training. Brief overview of schizophrenia. There are active phase symptoms, and you need to have at least 2, a delusion, hallucination, or disorganized speech of those. The duration onset, at least 1 month of active phase symptoms need to happen, and there needs to be continuous signs of it for 6 months or more. The onset is typically late teens to early 30s and peaks in mid-20s for males and late 20s for females. You can specify with schizophrenia whether what's showing up in terms of the active phase, delusions, hallucinations, disorganized speech. And then the best treatments, quick overview, is family psychoed, cognitive behavioral therapy, social skills training, supported employment, social learning, cognitive remediation, and then other ones include relapse prevention, family therapy aimed at reducing negative expressed emotions, helping with medication management. So how does one assess for schizophrenia? One important aspect of assessment of schizophrenia is finding out what stage of treatment you're in and whether they need hospitalization. So here are the signs for hospitalization: if there's a risk for suicide or aggression, if they're decompensating and not improving, if they need symptom stabilization and close monitoring by a psychiatrist, and if they're exhibiting signs of acute psychosis. In treatment, you start when they're in the acute phase, you are diagnosing and you are trying to alleviate the severe active phase symptoms. Hopefully you then get to the stabilization phase and you're monitoring and evaluating treatment, and you're hopefully over time reducing the symptoms more and more. And finally you get to the stable phase where the assessment's aligned with the goals, and now you really want to focus on reducing the chance of relapse. In treatment, 3 primary things to think. So if you see schizophrenia vignette on the exam, you're going to think hospitalization as a possibility, pharmacotherapy, and then psychosocial interventions. The hospitalization, you know the pieces of that, but it's really important if there's any of those risk symptoms to do so. Otherwise, antipsychotics and medication compliance is very important. The traditional antipsychotics help positive symptoms. The atypical alleviate both. Less a chance of tardive dyskinesia. And the psychosocial interventions are CBT, social skills, family, assertive community treatment, and supported employment. You really want to focus on preventing relapse, and that's important to encourage medication management. Assertive community treatment for schizophrenia. So the thing about schizophrenia is it's a pretty serious diagnosis, and they often need care in multiple ways, and just daily functioning when not medicated and stable is incredibly difficult. So community-based teams are considered helpful to prevent relapse, improve functioning, and really have accessibility 24 hours a day. They provide services like case management, assessment, crisis management, meds, mental health, housing, family education, and substance abuse programs. Schizophrenia treatment also supported employment. So schizophrenic patients, or patients with schizophrenia, I should say, do better when they are able to have a job and be engaging in the world. So supported employment helps folks with disabilities and assists them in maintaining employment, originally through like job crews and job coach, things like that. Surveys show that a significant majority want competitive employment in integrated community settings. So extrapyramidal symptoms are a combination of dystonia, akathisia, and Parkinsonism. But when you think of extrapyramidal, you could think of a pyramid shaking, because these are mostly movement things. So the traditional antipsychotics, they are used to alleviate positive symptoms primarily, by blocking dopamine receptors. And this relates to the dopamine hypothesis that schizophrenia is due to oversensitive dopamine receptors. The most important, there's a few side effects. So remember 3. Anticholinergic, that's you're not peeing, dry mouth. Extrapyramidal, that's motor stuff. And then neuroleptic, which is the rapid onset of motor and autonomic symptoms that can be fatal. So what is the mechanism of action? Well, we talked about it. It's a dopamine antagonist. So it lowers dopamine levels. And this is most helpful for positive symptoms. The atypical antipsychotics are also used to treat schizophrenia, but there's 2 pluses here. One, it helps more with the negative symptoms than the traditional ones do. And secondly, the extrapyramidal motor side effects are much less common, and they're less likely to cause tardive dyskinesia. So what are the negatives of switching to this one? Well, a negative is it's also more likely to produce or can produce a granulocytosis, which is a white blood cell problem. And both of them can do the neuroleptic malignant syndrome. But in any case, clozapine has also been found to be useful for bipolar disorder that hasn't responded to mood stabilizers. And there's a lot more uses for the atypical, including depression, alcohol, Huntington's disease, motor symptoms. And another disadvantage is that it has a slower onset. Tardive dyskinesia, this is about there's facial grimaces, involuntary movements. And neuroleptic malignant, this is like agitated, heart's racing, there's a tremor, it's kind of wild, and you can die and you stop immediately. A granulocytosis, which is associated with the atypical antipsychotic clozaril, it will cause a sore throat and fever and can be lethal, but that's the white blood cell. So what about bipolar 1 disorder? The diagnostic criteria here is that there needs to have been, and this is the only thing essential for the diagnosis, 1 manic episode for 1 week, or maybe they were hospitalized before they reached 7 days, and that counts too. Symptoms need to be most of the day, nearly every day, and 3+ symptoms on the list. It either leads to hospitalization or very serious impairment. The specifiers here, you can say whether there's the self-esteem, inflated esteem, sleep, speech, ideas, distractibility, goal-directed activities, psychomotor agitation, or excessive involvement in pleasurable activities. So what are the best treatments for bipolar? Here's the quick overview before we go a little deeper into it. Psychoeducation and cognitive therapy, as well as behavioral interventions that help with impulse control, like behavioral reversal, role reversal. So those are important. The referrals and adjuncts. Psychiatrist for medication eval and treatment is essential. If there's an acute crisis, it's important that there's inpatient hospitalization for stabilization. And sometimes there are partial hospitalization programs and day treatment depending on sort of the stage. The Alliance for the Mentally Ill for Family can be helpful for families, and Social Security can also be helpful. A very quick summary of treating bipolar 1 disorder. First of all, number 1 is psychopharm. Probably lithium is helpful for 80% of bipolar 1 patients. Anti-seizures and antipsychotics are also used. The goals is to stabilize manic or hypomanic episodes, have the client recognize that they need treatment, manage and eliminate the manic episodes that can be very dangerous through medication and therapy, increase the awareness of the consequences of the behavior, improve impulse control, deal with psychosocial problems secondary to the disorder, and maximize psychosocial functioning. And how do you do that? Psychoeducation is really important, as well as cognitive therapy and behavioral interventions. So impulse control, role-playing, behavioral reversal, role reversal. And it's going to be important to always ask, if you see bipolar 1 on a question, what are referrals and adjuncts that you might want to make? Because psychiatrist for medical evaluation and treatment is essential, and if there's acute crisis, inpatient hospitalization is necessary. Ongoing clinical concern is danger to self and others, especially when the mood is irritable. The mood stabilizing drugs. Lithium and carbamazepine are the ones to remember. Lithium is the drug of choice for bipolar disorder, especially with manic, not for rapid cycling though. It suppresses mood swings. Lithium, we'll talk a little bit more about lithium in a moment. One method of treating bipolar 1 disorder is family-focused treatment, which integrates the individual's family and focus on teaching all the members about bipolar disorder and its effects. It involves 3 phases: psychoed, communication enhancement training, and problem solving. One really interesting theory in bipolar disorder is that it's a result of abnormalities in the body's circadian rhythm. So interpersonal and social rhythm therapy is used to address the circadian rhythm, establish a better sleep-wake cycle, and then also deal with interpersonal events that might be the precipitant of rhythm dysregulation and source of distress. So how do you treat major depressive disorder? The 2 primary interventions you will see are psychotherapy and pharmacotherapy. In terms of pharmacotherapy, SSRIs, TCAs, and MAOIs are your go-to drugs. SSRIs are the number 1, and that's for serotonin for moderate to severe depression. Tricyclics, the TCAs, they're more for classic depression, which means that you have more vegetative symptoms. And the MAOIs are prescribed for people who aren't responding well to the other ones, or folks who have kind of atypical symptoms. There's other antidepressants out there like Effexor and Cymbalta that are SNRIs with norepinephrine. Psychotherapy has really, the literature emphasizes cognitive behavioral or interpersonal. And there are a couple other options is phototherapy, not just for major depression, but if there's a seasonal pattern to it. And finally, electroconvulsive therapy is still used, and it's used rarely though, but for those who have very severe endogenous depressions that just have not responded, it can actually be very helpful and save lives, really. So what interventions? So those are the overview of the interventions, but when you do cognitive behavioral, its focus is on problem solving, self-management, self-control. Acceptance and commitment therapy is one version, emotion focused is another. And for older adults, you might use reminiscence or life review instead. And you want to, similar to bipolar 1, make a psychiatric referral, especially for moderate to severe. Mild depression, probably no meds. And then if there's acute crisis and suicidality, then you want to do inpatient. Sometimes you'll have partial hospitalization programs as well. There are different types. So the 4 types to know about, or the 3 types, tricyclics, SSRIs, and MAOIs, but there's also other ones. The SSRIs are particularly effective for melancholic depression, and they're also prescribed for OCD, bulimia, panic, PTSD. They block the reuptake of serotonin. They take 2 to 4 weeks to kick in, and sometimes up to 6 to 8 for full effect. Be careful about serotonin syndrome if taken with an MAOI or other serotonergic agent, which it really shouldn't be. The tricyclics. So this was our first antidepressant created, and it's the most effective for those in particular that have decreased appetite and weight gain, or in weight loss, and early morning awakening. However, there's a high risk of suicide. These work by blocking reuptake of norepinephrine, serotonin, and or dopamine. This fits in with the catecholamine hypothesis, which says that norepinephrine deficiency is part of depression. The side effects are cardiotoxic and severe hypotension, which is a drop in blood pressure. Overdose can be lethal. So that's a major downside if you have a suicidal patient. The MAOIs include Parnate and Nardil, and they work by deactivating dopamine, norepinephrine, and serotonin. This is particularly useful for atypical depressions that are non-endogenous and have more vegetative, reverse vegetative symptoms, interpersonal sensitivity, anxiety. And they can cause, the most dangerous thing is they can cause a hypertensive crisis due to conjunction with tyramine, the amino acid tyramine. What would that look like? Well, a headache and stiff neck to start, but then just kind of like a flu, like nausea, vomiting, sweating. They need emergency treatment. So here's some of the new ones, NDRIs and SNRIs. NDRIs, Wellbutrin's the most popular one, and it's norepinephrine and dopamine reuptake, depressive phase of bipolar. The good thing about it is it doesn't have as many anticholinergic effects and is less toxic, but it can aggravate psychosis given the dopamine element to it. SNRIs works on serotonin and norepinephrine, and this has also been helping people with pain. It's less dangerous than the TCAs and faster, but it can increase your blood pressure, so that's something to watch for. Cymbalta is an example. Beck's cognitive therapy is also referred to as CBT and was originally developed as a treatment for depression, but has since been successfully applied to a number of other disorders, including anxiety, anorexia, bulimia, sexual dysfunction, and substance abuse. The primary goal of cognitive therapy is to help clients identify and alter dysfunctional and distorted assumptions. The main techniques are collaborative empiricism and Socratic questioning. So the cognitive targets of cognitive therapy. Practitioners target the following types of cognitions. First, cognitive schemas. These are underlying cognitive structures and rules that consist of core beliefs and that determine how individuals codify, categorize, and interpret their experiences. They are revealed in automatic thoughts and supported by cognitive distortions. Cognitive schemas develop early in life as the result of biological, developmental, and environmental factors. They can be either functional or dysfunctional, and may be dormant until they're activated by internal or external stress, especially stress caused by conditions similar to those under which they originally developed. Once activated, dysfunctional schemas impair the ability to think rationally and predispose the individual to depression or other disorders. Automatic thoughts. These are surface-level cognitions that intercede between an event or stimulus and the individual's emotional and behavioral reactions. Automatic thoughts are not necessarily associated with psychological dysfunction, but they contribute to dysfunction when they're the result of maladaptive schemas and are frequent, persistent, and then not critically examined. Cognitive distortions. These are systematic errors or biases in information processing and are the link between maladaptive cognitive schemas and negative automatic thoughts. Common distortions include arbitrary inference, which is when you draw conclusions without corroborative evidence, overgeneralization, when you draw general conclusions on the basis of a single event, selective abstraction, attending to detail while ignoring the total context, personalization, erroneously attributing external events to oneself, dichotomous thinking, thinking in polarized either-or ways, and emotional reasoning, believing things are a certain way because one feels they are that way. Like automatic thoughts, cognitive distortions become problematic when they are pervasive and are not critically examined or challenged. A cognitive profile. According to Beck, each psychological disorder is characterized by a different cognitive profile. For example, depression involves the cognitive triad of a negative view of oneself, the world, and the future, while the cognitive profile for anxiety reflects an excessive form of normal survival techniques and consists of unrealistic fears about physical and psychological threats. Characteristics and strategies of cognitive therapy. Cognitive therapy is distinguished from other CBT therapies by several characteristics. First, it relies on collaborative empiricism. This involves developing a collaborative therapist-client relationship and gathering evidence to test hypotheses about the client's beliefs and assumptions. Second, it is time-limited treatment, with the average length of therapy being 15 sessions and sessions being structured and goal-oriented. With regard to the latter, the first session ordinarily addresses the following goals. A. Establishing rapport and trust. B. Socializing the client to cognitive therapy. C. Educating the client about their disorder, the cognitive model, and the therapy process. D. Normalizing the client's difficulties and instilling hope. E. Determining and, if necessary, correcting the client's expectations about therapy. F. Collecting additional information about the client's problems. And G. Developing a goal list. Third, while the focus of cognitive therapy is on the client's current experiences, historical material may be addressed to clarify his or her core beliefs. Fourth, cognitive therapy assumes that relevant cognitions become accessible and modifiable only with affect arousal, and consequently imagery and other techniques are used to elicit affect. Fifth, questioning is a primary therapeutic tool and often takes the form of Socratic dialogue, which is also known as guided discovery, and involves asking questions that are designed to help the client reach logical conclusions about a problem and its consequences. Six, the relapse prevention is a focus throughout treatment. For instance, during the course of therapy, the therapist emphasizes the client's part in causing change in mood and behavior, and toward the end, the therapist works with the client to develop a self-therapy plan. CT incorporates a variety of behavioral therapy techniques. Behavioral strategies include activity scheduling, behavior rehearsal, social skills training, and relaxation. Cognitive strategies include the downward arrow, if so, then what? Questioning the evidence, decatastrophizing, mental imagery, and cognitive rehearsal. Clients are often given homework assignments, and an early assignment requires the client to keep a daily record of dysfunctional thoughts in order to identify the client's automatic thoughts. The specific techniques used in therapy depend on the nature and severity of the client's symptoms. For example, behavioral techniques designed to increase the client's overall activity level are often the initial interventions for clients with severe depression, while cognitive techniques are usually the initial interventions for those with mild to moderate depression. Attribution retraining, another cognitive restructuring technique. Attribution retraining focuses on altering the individual's perceptions of the causes of their problematic behavior. And this has been successfully used to treat depression, anxiety, alcoholism, and several other disorders, as well as to improve the academic performance of underachieving students. Attribution retraining is consistent with the assumptions of the reformulated learned helplessness model and with optimistic explanatory style that is promoted in Seligman's theory of learned optimism. Its goal is to help clients attribute their failures to external, unstable, and specific factors, and successes to internal, stable, and global factors. Problem-solving therapy. This is these are cognitive and behavioral strategies to help clients deal effectively with problematic external events. So stress inoculation is actually one of those. And then problem-solving therapy was originally described by Dzurilla and Goldfried in 1971. It's been updated many times since. Its most recent version proposes that problem-solving outcomes are determined primarily by two factors. One, problem orientation refers to relatively stable cognitive schemas that can be either positive or negative, and that represent the person's views about problems and his or her ability to successfully solve them. Problem-solving style refers to the activities the individual engages in when solving problems. PST distinguishes between rational, impulsive, careless, and avoidant styles, with the rational style being identified as the only one that's likely to result in adaptive problem solutions. It's characterized by a reliance on 5 skills: recognizing the problem, defining the problem, generating alternate solutions, choosing the best solution, and implementing and evaluating the chosen solution. In therapy, several strategies are used to help clients adopt a positive problem-solving orientation and rational problem-solving style, including psychoeducation, guided discussion, role-playing, and homework assignments. REM self-control therapy is a brief form of therapy that is usually conducted as a group therapy. It's based on the assumption that deficits in 3 aspects of self-control increase a person's vulnerability to depression and make it difficult to deal effectively with depressive symptoms. So first is self-monitoring. Depressed people selectively attend to negative events and to the immediate versus delayed consequences of their behavior. Self-evaluation. People who are depressed make inaccurate internal attributions and compare their behavior to standards that are excessively rigid and perfectionistic. And finally, self-reinforcement. Depressed individuals engage in low rates of self-reward and high rates of self-punishment. Therapy sessions and behavioral homework assignments correspond to the 3 aspects of self-control. During the self-monitoring phase of therapy, the client is taught to monitor negative self-statements and positive outcomes. And during the self-evaluation phase, he or she is taught to set realistic goals and to make appropriate attributions for his or her behaviors. Then finally, during the self-reinforcement phase, the client learns to reinforce him or herself with positive self-statements and activities for working toward or achieving his or her goals. Lewinson's behavioral model attributes depression to a low rate of response contingent reinforcement due to inadequate reinforcing stimuli in the environment and/or the individual's lack of skill in obtaining reinforcement. According to Lewinson, when a person's behaviors, for instance, attempts to interact with family members or coworkers, are not reinforced, those behaviors extinguish. He also proposed that in addition to eliminating or reducing certain behaviors, a low rate of response contingent reinforcement elicits pessimism, low self-esteem, and other features that are associated with depression. In terms of treatment, Lewinson initially focused on reactivating depressed patients by increasing their activity levels and access to reinforcing events, but subsequently incorporated cognitive techniques similar to those developed by Beck. Interestingly, however, there has been a renewed interest in recent years in behavioral activation approaches for depression that utilize behavioral strategies only. So what is separation anxiety? Separation anxiety is a developmentally inappropriate anxiety of being away from an attachment figure. You need to have 3 or more symptoms from the list involving distress around separation, fear of being alone, physical symptoms that emerge, and with kids there's often school refusal. Now separation anxiety can also be a diagnosis for adults. It's important though that with kids it's only a month is needed, whereas adults 6 months are needed. The onset is after toddler and infant years, of course, where it's very normal to have that kind of distress. So 4 weeks for kids, 6 months for adults. For adults, the attachment figure could be a partner. It could even be their own child. Okay, and how do you treat separation anxiety? First of all, you need to assess for it, and what are the assessments that are used? Self-report inventories are used, rating scales, and structured interviews. And the primary treatments here are behavioral and cognitive. In vivo exposure, systematic desensitization, contingency management, and modeling are all behavioral interventions that are used. And one thing that's important to remember, and could be on the test, is that the child really needs to go back to school immediately. So if they've been skipping school, they need to go back. So with specific phobia, so what is the treatment for specific phobias? So to go a little deeper in, exposure is the preferred treatment, and in vivo is preferred of the exposure treatments. For a blood injection injury, combining exposure with applied tension can be helpful. And the more prolonged the exposure, the better. But sometimes, in order to even have compliance with the treatment, a gradual increase is desired. In terms of cognitive interventions, cognitive therapy alone just isn't as effective as in vivo exposure, particularly for claustrophobia. But you can learn things like cognitive self-control, and you can use CBT in combination with the in vivo exposure to kind of gradually desensitize yourself. Systematic desensitization is the first intervention we'll talk about that's based upon Wolpe's counter conditioning. This was an application of reciprocal inhibition for eliminating anxiety responses. So what they do is they hierarchically arrange anxiety-evoking events and pair it with relaxation. So as you can see, there's 3 different sizes of spiders, and ostensibly this man has worked his way up to being able to stand near that biggest spider. Little does he know there's a much bigger spider behind him. So he may or may not be prepared for that. There are 4 stages to this process. The first is relaxation training. So the therapist needs to teach the client to use a technique that will produce relaxation. So this could be progressive relaxation, for example. And when you with this technique, you systematically tense and relax all of the body's major muscle groups. It often begins with a standard cue like, take a deep breath, or you say, I'm relaxed. Alternatively, clients may imagine a relaxing scene, such as lying on the beach on a warm, sunny day. After relaxation training is the construction of an anxiety hierarchy. So the client and therapist are going to work together to think of events related to this target behavior, so maybe being able to hold a spider, that are ordered on the basis of the amount of anxiety they evoke. So to ensure that this hierarchy represents the full range of anxiety levels, and that they're also equidistant in terms of amount they will elicit. So part of why this cartoon is, funny if you think it's funny, is because you can see the spiders have been very carefully titrated in terms of how much they go up in terms of size. They're still in containers, and that's a pretty big leap to get from the biggest spider in the container to the little spider coming in through the door. How do you measure that? Well, there's a scale called the Subjective Units of Distress Scale, SUDS, and this involves having the client rate each event on a scale from 0, which is complete relaxation, to 100, which is the highest level of anxiety the client can imagine. And then the events are selected on the basis of the client's rating, so that the hierarchy contains about 10 to 15 items. Third, desensitization and imagination. Relaxation is then paired with a presentation of items in the hierarchy, beginning, of course, with the least anxiety-evoking item. The therapist then instructs the client to relax, using whatever technique they learned during the first stage of treatment. Once the client has achieved the state of relaxation, the therapist instructs him or her to imagine the appropriate anxiety hierarchy item. The client signals the therapist whenever he or she feels anxious, and the therapist will help the client reestablish the relaxation. Excuse me. When the client's able to imagine an item without experiencing anxiety, then you move on in the hierarchy. So this is repeated until the client can imagine the most anxiety-arousing item without experiencing anxiety, such as that big spider coming through the door. So that's an imagination. The 4th stage is when you have been desensitized, or the client's been desensitized to about 75 to 85% of their anxiety hierarchy items. Then they begin to confront the situations in vivo, as in life, if that's actually feasible. So in vivo is highly structured and involves facing in real life only the situations that correspond to hierarchy items that have been successfully desensitized in imagination. So you're not going to throw them into something that they haven't learned to cope with, at least in their mind. So there's something called the dismantling strategy to keep in mind here. And several investigators have used this to identify what's responsible for why this works, for why this can benefit clients. And when they have used the dismantling strategy, they compare the effects of various components of treatment by administering different components to different groups. The results showed that training in an incompatible response and gradual exposure to anxiety-evoking events are not the essential components of systematic desensitization, even if they might have some facilitating effect. However, it's the extinction, the repeated exposure to the conditioned stimulus without the presence of the unconditioned stimulus, that's the primary factor responsible for its effects. And Bandura actually happens to be one of the researchers who did that work, along with someone named Lang in 1969. Finally, in terms of classical conditioning interventions, we have interventions that are based on classical extinction. The two-factor theory of learning proposes, this is Maurer, M-O-W-R-E-R, 1960, proposes that the development of a phobic response is the result of both classical and operant conditioning. A person develops an anxiety reaction to a neutral stimulus when it's paired with an unconditioned stimulus that naturally elicits anxiety, or whatever aversive response, so that's the classical conditioning part. And then the operant conditioning part is the person then avoids that conditioned stimulus, like Albert's white rabbit, let's say, that the operant conditioning would kick in for little Albert when throughout his life he then never touches white animals, he avoids them. Because when he avoids those white animals, doesn't go to the zoo, leaves people's houses with white rabbits, he's enabled to avoid anxiety, which is now operant conditioning, negative reinforcement. When he leaves, that stress went away, leaving is reinforced, so people learn to avoid and escape. So the techniques, there are a number of techniques that are used to produce classical extinction, and they all involve repeatedly exposing the client to the conditioned stimulus without the unconditioned stimulus. So you're getting rid of, extinction always means you're getting rid of that pairing that caused some trouble from the past. Key to this, though, is also that element of operant conditioning, where people have learned, because it's negatively reinforced, to leave situations, to not take elevators, to walk up the stairs, even if it's many, many flights, so they don't have to deal with the conditioned response, which really just continues to amplify it. It gets worse. So three different approaches to classical extinction, and based on what we've already talked about with counter conditioning and aversive conditioning, there is, again, doing it in real life and doing it in imagination. So if you do it in real life, pairing it with the operant conditioning piece is called response prevention. So in vivo exposure with response prevention. That's a key term to remember. The client's exposed to that stimulus for a prolonged period of time. So instead of systematic desensitization, you are putting that person in an elevator and they are not leaving. For example, it can also be used with OCD, and you expose the client to obsessional cues like dirt, and you don't let them engage in their usual rituals. So they might have to sit with their hands in a bucket of dirt, and they don't get to go wash their hands under scalding hot water. So they're also not escaping. There are several variations of this. So flooding, key term, is when you're just exposed to the most anxiety or fear-arousing stimulus for a prolonged period of time. So that would, for example, be putting your hands in dirt for some folks with OCD. Graduated graded exposure is similar to systematic desensitization. It begins with exposure to situations that produce minimal anxiety, and then you progress to those that evoke more. That's helpful for reducing the fear and avoidance that can be caused by initial exposure to high anxiety arousing situations. So if a client's not ready to put their hands in a bucket of dirt, and maybe you even have them try it, it doesn't work, and they're never going to do it again, then you want to start with things that are a little bit less intense. But this is different than systematic desensitization in that they are still flooded with it. They still have to sit with 45 minutes to really address that issue. So what have studies found about in vivo with response prevention? The exposure and the response prevention are both essential. You can't have one without the other. And prolonged exposure to the anxiety-arousing stimulus is usually more effective than several brief exposures. And actually, short duration might actually increase sensitivity to fear of stimulus, because then you've just traumatized them without them really getting to learn, okay, that unconditioned stimulus is not here anymore, the one that caused fear. High anxiety provocation during exposure may not be necessary for it to be successful. So some investigators found that the simultaneous use of a tranquilizer, which lowers anxiety, can actually enhance it. So you're really speeding up their association, like, look, this is not necessary to feel this anxious during it. You don't need to get them anxious or then normal and then calm them down. You want them to really know, I can sit on a plane and be calm. In some situations, self-directed exposure following training by a therapist is just as effective as therapist-directed exposure. So you can prep them to go do their elevator training session, riding it up and down all day, and they don't necessarily need the therapist there. It can be just as effective for them to do it on their own. And as a clinician, you would determine, based on lots of factors, if that was the case for your client. Group exposure can also be as effective as individual treatment. And partner-assisted exposure has been found to be effective for agoraphobia and OCD. Finally, interoceptive exposure has been found effective for reducing anxiety associated with panic attacks, PTSD, and other anxiety-related disorders. So that means using strategies that are designed to evoke the feared bodily cues that are associated with fear and anxiety reactions. So spitting in a chair, breathing in a paper bag, cardiovascular exercise, for example. So people learn, I can feel dizzy, my heart can be racing, I can be out of breath, and I'm okay, because it's no longer associated with the doctor's office or the elevator. You can sit with that therapist and say, hey, I'm out of breath and I'm actually okay. All right, so that's a lot of information on in vivo exposure with response prevention. What about implosive therapy? Like in vivo exposure with response prevention, implosive therapy is based on the assumption that certain events, conditioned stimuli, are consistently avoided to reduce the anxiety that prolonged exposure would cause. Implosive therapy is conducted in the imagination, and it involves presenting the feared stimulus vividly enough so it arouses high levels of anxiety. Stampful, let's move on to the next slide. Stampful is the main developer of the implosive therapy technique, and he believed that avoiding behaviors is learned during childhood, and that it actually, there might be a fear of snakes, but it also represents a conflict that's related to sexual or aggressive impulses. So consequently, the images that you use during implosive therapy are embellished with psychodynamic themes. A snake-phobic client, for example, might be asked to imagine a scene that not only involves a personal encounter with a snake, but that also emphasizes the sexual symbolism of snakes. Research showed, however, that it really does seem like the factor that is helpful in implosive therapy is the exposure to that imagined fearful stimulus and counter conditioning more than the sexual interpretation. Finally, we're going to talk about EMDR. There isn't a slide for this one. So what is social anxiety disorder? It is a persistent fear of one or more social performance situations. The situation usually involves unfamiliar people, and there's a fear of scrutiny. They fear that actions will result in embarrassment, and exposure to the situation provokes immediate anxiety, which is often situationally bound panic attack. So these are panic attacks that can be predicted given the feared situation. The distress has to be clinically significant for it to be a disorder. And what is the duration and onset? Can you remember? Well, it's persistent, typically 6+ months. So like generalized anxiety disorder, which is a year, you need to really have shown the symptoms for this for a very long time. I got to double check on the generalized anxiety disorder. So with social anxiety disorder, how do you treat it? First of all, when we go through our treatment planning process, you want to assess And then you want to establish your goals and objectives. Good goals for social anxiety is just to reduce the fear, which to enable the improved functioning, and to deal with the symptoms. So deal with possible interpersonal or other deficits that have occurred secondary to the anxiety problems. The interventions used often are cognitive behavioral therapies, specifically cognitive restructuring. So really think about it. You want to learn to rethink things. Like if you think that there's something so embarrassing about if you sneeze in public, really restructuring the way you understand things, explain things, and also exposure is helpful. Applied relaxation, social skills training, and medication management are all other interventions that can be of use. This is also a case where you want to make a referral to a psychiatrist for a medical evaluation and treatment. And exposure with response prevention is particularly helpful here. SSRIs or SNRIs or even beta blockers will be the preferred medication. And the last thing to say on this is that there is a performance-only specifier. So panic disorder is now a diagnosis. The symptoms are recurrent panic attacks, which are abrupt surges of intense fear. It reaches a peak within minutes. And here's the essential diagnostic criteria. One attack needs to be followed by 1 month of concern, worried about it. So these are recurrent panic attacks and the 1 month of concern that it's going to happen again. The median onset is 20 to 24 years. You have to rule out hyperthyroidism, cardiac arrhythmia, and other medical conditions. Symptoms include, and specifiers and notes you can add are palpitation, sweating, trembling, chest pain, derealization, fear of losing control, among a few others. So how do you treat panic disorder? I'll go a little more into this, but just to summarize, you're looking at cognitive behavioral, psychoed type stuff, as well as psychiatric referrals. So when we say cognitive behavioral, what we're talking about is CBT. So there is specifically a panic-focused CBT that we will discuss. When we talk about psychopharm, we're thinking that it could either be the SSRIs or SNRIs, and there's also benzodiazepines that would be used, hopefully not on a long-term basis. The risk for relapse is high if it's just drug treatment alone. So therapy is actually really important here. CBT and meds are not more effective long-term than just the CBT, unlike ADHD where it really isn't very impactful without the medication. So you want to, when you have a panic disorder client in your office, you want to think CBT, relaxation, and then educating them about the anxiety response so they know they're not actually having a heart attack. Also make sure they get the medical and psychiatric evaluation. So quickly, panic control treatment, CBT, has psychoed, cognitive restructuring, breathing retraining, and interoceptive conditioning to reduce fear about bodily sensations. Panic-focused CBT, the components of, it also integrates a component of relapse prevention, and you want to, with the interoceptive exposure, kind of expose yourself to both the internal and external cues that are triggers, and then you might like spin in a chair. So if that body sensation or hyperventilating or getting dizzy, you kind of create that, and then you practice with the therapist how to relax and deal with those somatic symptoms that have become so scary. And the benzodiazepines, which are for anxiety. You have anxiolytics, sedative hypnotics, and non-benzo sedatives. They have their own side effects, though, which include being overly sedated or too inhibited. Agoraphobia is a fear of 2 or more situations. So, when you want to treat agoraphobia, let's just say a little bit more. When you read a question, what are the goals? So always you want to improve functioning. So how do you do that in this case? Reduce fear. And what does that look like? A goal would be to achieve independent travel from home, to deal with possible interpersonal and other deficits that have occurred secondary to the anxiety problems. The interventions are mostly CBT. This is similar to other anxiety. CBT, relaxation, and medication, yet again. And you want to make sure you have both cognitive and exposure-based components, in particular with agoraphobia. So similar to other phobias, with agoraphobia, the exposure is really going to be emphasized. So in vivo exposure with response prevention is what you should think when you see the word agoraphobia. In vivo exposure with response prevention. Research is mixed as to whether graded is better, but intensive, again, may have better long-term effects. Generalized anxiety disorder is a disorder you'll see frequently. The criteria is to have 3 or more symptoms from the list in the DSM, which includes both symptoms of anxiety and thinking, like difficulty concentrating, as well as physiological symptoms like fatigue and muscle tension, gastrointestinal stuff. People experience the anxiety as very hard to control, and it lasts over 6 months. So not a year, 6 months, 6 months, 6 months. The best treatments here are CBT, biofeedback and relaxation, self-monitoring. You also want to make referrals for the medical doctor and the psychiatrist. The symptoms: restless, fatigued, mind goes blank, they're irritable, they're tense, they have trouble sleeping. What to remember, that it needs to be 6 months or more. 6 months or more and constant. They must find it difficult to control and have 3 or more of the symptoms listed. The treatment is CBT or CBT and drugs, like SSRIs. So the top 3 treatments for generalized anxiety disorder are CBT, relaxation, and pharmacotherapy. So think generalized anxiety, and you're going, like you often do with depression and anxiety, to the cognitive behavioral models. But with anxiety, learning how to relax is important. And particularly with generalized anxiety, there's a lot of physiological aspects to it. So learning progressive muscle relaxation can help with the muscle tension. Regular practice while imagining the feared situation. So in this case, of course, there's a lot of different things that are feared, but practicing with different things that are worried about, how to relax at the same time. Benzos are used, antidepressants, venlafaxine and imipramine, and buspirone is also used. So progressive muscle relaxation involves sitting, tensing your muscles, and then relaxing them, tensing and then relaxing, tensing and relaxing. So by tensing, you actually learn how to relax. When you treat generalized anxiety with the applied relaxation technique, you learn via different muscle groups in a row. So once you learn that, you actually cut out the tensing phase and move straight to relaxing each muscle. Next, you learn to associate a certain cue, like thinking serenity now, with a relaxed state. And then you learn to relax really quickly. So finally, the end result, this is kind of the goal, is you practice a relaxation technique in real-world anxiety-provoking situations. So in terms of treatment, you want to be able to assess and then give them the coping skills, and then finally move on to application and maintenance of the treatment success. One other technique with generalized anxiety is the what-if technique, and this is to really address the catastrophic thinking aspect. So you divide a piece of paper into 3 columns, and in the first you write a feared negative outcome, in the second write a what if, in the third write what you would actually do. So check in with yourself to see if actually confronting the fear and making a plan reduces the anxiety. If it leads to another fear, such as embarrassment, then make that next fear in the first column and continue. See if you can get to a place of calm and security. Quick overview of OCD. It is characterized by obsessions and or compulsions, and it's essential that these are time-consuming and distressing, an hour or more a day, and causing impairment, or at the, even if not an hour, causing significant impairment, repetitive behaviors. The duration and onset is typically earlier age of onset in males, but it evens out as they get older. So as we're older, it's actually more common in women than men. The specifiers. So you want to specify if it's either an obsession or a compulsion. So obsessions are persistent thoughts, impulses, or images that are intrusive and they're distressing. The compulsion is a behavior or mental act that the person feels driven to perform, and that's usually to kind of reduce the anxiety caused by the obsession. So how do you treat OCD? Interventions, so exposure and response prevention. Again, with a lot of these anxiety disorders, exposure with response prevention is the tendency. Cognitive therapy, acceptance and commitment therapy. Relapse prevention. Thought stopping is one that you don't see on all of the lists. So thought stopping, since there's such intrusive thinking, thought stopping, relaxation skills, as always, and medication management. And of course, this is a pretty genetically based, endogenous disorder oftentimes. So you want to make the psychiatric and medical evaluation referrals. OCD is about recurrent obsessions and compulsions. The treatment is either SSRIs or tricyclics, and in terms of therapy, exposure with response prevention is thought to be important. So ask yourself right now, if you had to say 3 aspects of treating OCD, what are those 3 aspects? So including, of course, not only the therapy stuff, but the psychopharm. So that gives away that psychopharm is 1, and there's 2. You can think about the therapies in terms of the exposure with response prevention and the cognitive behavioral therapy. The goal here is really that the client has strategies to interrupt the obsessions and compulsions and to thus improve daily functioning so that there's a reduction in the time that's involved in spending on obsessions and compulsions. And if there's any underlying issues that are leading to them, you want to work to resolve them. Autogenics is another piece. So for OCD, when you do exposure with response prevention, you're exposing the person to the situations that trigger the obsessions. So whatever the procedure is, you're blocking the ability for that patient to perform the typical obsessive ritual. And you supplement it with the thought stopping and cognitive interventions that address the dysfunctional beliefs that might happen. So if the person is afraid of germs and they stick their hands in a bucket of dirt and they're not able to go grab the hand sanitizer, they have to just stay there, then you can work with them in terms of how to stop the thoughts like, oh no, I'm going to die from the germs, or whatever they might be. Now we're going to talk about other cognitive restructuring techniques in addition to Beck, Meichenbaum, and Ellis. And the interventions described here are, they conceptualize maladaptive behaviors as the result of disturbances in thinking. They are narrower in focus and utilize a more restricted range of strategies. Thought stopping. Thought stopping entails eliminating obsessive rumination, self-criticism, depressive or anxiety-arousing ideas, and really any other unwanted or unproductive thoughts by using such techniques as covertly yelling, stop, 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 or snapping a rubber band placed around the wrist whenever unwanted thoughts occur. Thought stopping is often combined with covert assertion, which involves making alternative, assertive self-statements following thought stopping. We're going to do a whirlwind tour of body dysmorphic disorder, but this is in the OCD category, not the feeding and eating disorders category. It's a preoccupation with an imagined defect in appearance. At some point, they perform repetitive behaviors or mental acts because of this defect, and it causes clinically significant distress. Instead of seeking psychotherapy, you might see that there's a seeking plastic surgery or medical treatment. You can use different specifiers in terms of good or fair insight or absent insight delusional beliefs. So some people know they're being, that it's kind of an irrational fear, but it's still preoccupying them. Whereas on the hills, you saw, what's her name, Heidi, turn herself into a Barbie doll and really harm her body deeply because of the excessive amount of plastic surgery she got. And she came back later and really did some healing work, and regretted it. So that's a Hills reference. Body dysmorphic disorder, you can see that there's 4 criteria: the perceived defect, at some point there's been repetitive behavior, number 3, clinically significant distress, and number 4, it's not better explained by concerns with body fat in someone who criteria meets the criteria for an eating disorder. So that's a good note. So what about treating body dysmorphic disorder? So you want to work with CBT, yet again, especially because we're dealing with the OCD territory. Cognitive restructuring, exposure with response prevention, behavioral experiments, mirror perceptual retraining, sometimes antidepressants, and then also working with relapse prevention. So what is mirror retraining? This is that perceptual retraining uses mirrors to help the patient learn to see their entire body without excessive checking. And rather than focusing on disliked details, to learn to describe oneself in neutral and non-judgmental ways. So you can see how that's kind of related to exposure therapy. Moving into this trauma and stressor disorders. First is reactive attachment. What you need to know is that you need to have 2+ symptoms from the list. The diagnostic criteria is that you have real inhibition and withdrawal and behavior toward caregivers. The onset is between 9 months and 5 years. This is a childhood disorder. The kid does not respond to comfort, and it must be due to extremely insufficient care. Disinhibited social engagement disorder can be quite troubling to actually witness. They are inappropriate and excessively familiar with strangers. And again, this is also due to insufficient care. Acute stress disorder lasts 3 days to 1 month, whereas for PTSD standardly, it is anything more than a month. So as soon as you hit the month line, you're moving into PTSD category. 9 symptoms following a trauma of 5 different categories: intrusion, negative mood, dissociation, avoidance, and arousal. So as we move further into the trauma disorders, let's consider the basics of treatment for both the acute stress and post-traumatic stress disorder with different lengths. And we'll talk more about post-traumatic stress in a minute. But the kind of underlying bones of the treatment are that you're using a combination of cognitive behavioral therapy and pharmacotherapy. The strategies here are psychoeducation, cognitive restructuring, and because there can be such autonomic reactions, you want to do some breath training, relaxation training, stress inoculation training. So really helping the person be able to feel safe in their bodies again. And you want to do some form of exposure. So you certainly want to be mindful of what that exposure looks like. But kind of exposing them, they are triggered throughout the day. So it's not about throwing them back and flooding them in terms of re-triggering the trauma, but at the same time helping them learn to relax when triggers come up. So when there are police lights, if there was a trauma with the police, learning that police lights to kind of calm that response. SSRIs can be adjunctive, and particularly for non-combat related PTSD. Seeking safety is an intervention, and we'll talk more about EMDR and stress inoculation training. A single session debrief after a traumatic event is not helpful, so that's important to keep in mind. And when you think about referrals, think about not only the psychiatric and medical evaluation that's necessary, but think about PTSD support groups, because people feel very isolated and alone, and it can provide a lot of relief. PTSD has been changed. Now sexual violence can be included. Criteria varies exposure on the age. To actual or threatened death, injury, violence. We need to have one or more intrusion symptoms.
Here are the requirements.
And that has led to avoidance,
exposure
change
to
arousal. These are
the traumatic event,
well,
which
that you have
could
to
be
be avoiding
death,
things and have
serious
physiological
injury, or
arousal
sexual
as a result.
violence. And there are different ways
1
in
to 2
which
years
that can happen. It can be directly,
is
it
typical,
can be witnessing or learning that it happened to
without
someone
being
close, or finally
symptom-free.
being exposed to the details repeatedly, except when it's through the media. Secondly, there needs to be presence of symptoms as a result, and at least one of them must be intrusion symptoms, and that would include recurrent involuntary distressing memories of the event, dissociative reactions, intense or prolonged psychological distress when reminded, and physiological reactions. Thirdly, There needs to be a persistent avoidance of stimuli that's associated with the event, and that can be evidenced by one or both of the following, either avoiding the memories, thoughts, feelings as internal things, or avoiding external reminders that will elicit the distressing memories, thoughts, and feelings. So first is exposure to a trauma. 2 is presence of at least one kind of intrusive symptom. 3rd is persistent avoidance of associated stimuli. And then 4th, negative changes in cognition or mood are associated with the event. And that needs to be evidenced by at least 2 of the following: inability to remember an important aspect, persistent negative beliefs about oneself and others in the world, persistent distorted cognitions related to the event's cause or consequences, markedly diminished interest in significant activities, feelings of detachment from others, and persistent inability to experience positive emotions. 6, and finally, there must be a marked change in arousal and reactivity associated with the event as evidenced by at least 2 of the following: irritable behavior and angry outbursts, reckless or destructive behavior, hypervigilance, exaggerated startle response, impaired concentration, and sleep disturbance. So 2 of those. So 6 things: 1, exposure to the trauma; 2, presence of one intrusive symptom; 3, persistent avoidance of internal or external stimuli; 4, negative changes in cognition or mood; and 5, marked change in arousal levels. This is different for children under the age of 6.
So what's the overview of PTSD? The exposure to the traumatic event with resulting symptoms in 4 categories. Can you name the 4 categories? They are intrusive, avoidance, negative alterations in mood and cognition, and a sense of arousal. You need to have 1 of the intrusive and avoidance and 2 of the negative alterations and arousal. The event must involve actual threatened death, serious injury, or sexual violence. And there are different criteria for kids, so you only need to have symptoms in 3 of the categories. Similar, one of intrusive and avoidance, and then 2 in arousal. So you don't have to have the negative alteration. The event may also be witnessed in person, and if with a kid, and learn that it occurred to their caregiver. The duration needs to be over a month. So that's where you're differentiating between the acute stress and the PTSD. A delayed onset is a specifier that's important to know of 6 months without full symptoms, and then there it comes. The specifiers, in addition, are whether there is accompanying depersonalization, derealization, whether there is a delayed expression, like we said, and unfortunately, the delayed expression is actually a worse prognosis. The interventions, which we will go more into, but just to sum them up: prolonged exposure, cognitive processing, seeking safety, stress inoculation, EMDR, and then, of course, the appropriate medical and psychiatric referrals. To quickly summarize acute distress, you're exposed to the same type of events that cause PTSD and 9 or more symptoms from any of 5 categories. The exposure types, you need to experience it, witness it, learn it occurred to someone close, or have repeated exposure to aversive details of the event. This is 3 days to 1 month. The 5 categories are the same as PTSD, and also dissociation. That's an important one to remember. The best treatment is the same as with PTSD, pretty much. Hopefully there is not as necessary of long-term treatment here. So when it comes to treating PTSD, there is actually a trauma-focused cognitive behavioral therapy model, and the basis of it is that patients are taught stress management skills. The therapist helps the patient develop a narrative, verbal, written, artistic, about the traumatic event, and then they may be exposed to reminders about the trauma and are taught how to cope with future reminders. So that's like the police lights. Through the process, the patient learns how to reprocess their thoughts, feelings, and behaviors. So, what do you think? You think, if you have to be really bare bones about it, you think exposure with response prevention. Oh, I'm sorry, this is... I don't know about the response prevention, actually just exposure, cognitive processing, stress inoculation, EMDR, and then, of course, the medical referral. Stress inoculation training. This was designed to help people deal with stress by increasing their coping skills. Treatment involves 3 phases. 1, the cognitive preparation phase, also known as the conceptualization phase. It's primarily educational and involves helping the client understand his or her behavioral and cognitive responses to stressful situations. B, during the skills acquisition and rehearsal phase, the client learns and rehearses a variety of coping skills. Specific interventions during this phase include direct action techniques like relaxation, pleasant imagery, arranging escape routes, and cognitive techniques, replacing negative self-statements with coping self-statements. And C, in the final application and follow-through phase, the client applies the coping skills he or she has acquired to imagined, filmed, and in vivo stress-producing situations. So you can think of that as 1, education and cognitive preparation, 2, coping skills acquisition, and 3, application of skills in imagination and in vivo. EMDR was originally developed as an intervention for PTSD, but it's now used to treat a variety of symptoms and disorders like panic attacks, phobias, depression, and substance use. It's based on this assumption that when you're exposed to trauma, you are blocked from a very adaptive information processing mechanism that is neurophysiological. So by combining rapid lateral eye movements, which are believed to trigger that mechanism, with exposure to the trauma or fear with techniques drawn from CBT or psychodynamic, that together it can treat the trauma and reopen access to that information processing. There is controversy. It has been found to be effective for PTSD, but there's controversy as to whether this has anything to do with the eye movements, which seems and sounds a little silly, but you know what? You never know. Based on results of meta-analysis of research, Davidson and Parker have concluded that the eye movements may be unnecessary and that it's really about imaginal exposure. Adjustment disorder has to have onset from some event within 3 months and must remit within 6 months. This is an emotional or behavioral response to a stressor, and it's just not proportional to what happened. Okay, so treating adjustment disorder, you want to think about similar treatments that you would give for anxiety and depression disorders in general. The goal you want to identify what the stressor was, because this is a short-term thing, right? So there was a specific stressor that precipitated this. So helping the client identify what that actually was, and then moving deeper into actually alleviating the current symptoms, whether it's anxiety, depression, or conduct disturbance. You also want, in this kind of therapy, to help prevent this from happening in the future. So you're not only teaching them coping skills to kind of work through the current symptoms, but you want to decrease their vulnerability to the development of future stressors. Types of therapy include CBT, interpersonal therapy. Because it's a short-term thing, it can also be solution-focused, brief psychodynamic, kind of shorter-term therapies. And you'll see, because this is often like an acute stressor, you might have crisis intervention strategies here as well. Make sure, however, to assess for more serious psychopathology. So if there's a test question that is talking about, that's just talking about someone, just got divorced, but there's signs that maybe this is a more long-standing problem, just make sure that that actually gets assessed for it. You don't just take it for granted that because there was an acute stressor recently that it's not a more long-standing thing. So referring to a psychiatrist for medical evaluation is also useful. Moving into the dissociative disorders, somatic, feeding, elimination, and sleep-wake. What are the dissociative disorders? Well, you have DID, dissociative amnesia, depersonalization, derealization. There are also disorders that are particularly related to somatic symptoms. The ones to know about in particular are conversion disorder and fictitious. Conversion is a disturbance in voluntary or sensory function, which leads to a really serious condition, and it's incompatible with anything that is actually medically diagnosable. For fictitious disorder, this is a purposeful falsification of symptoms without a clear external reward versus malingering where there's, some sort of external reward. With fictitious disorder, it could be on the self or the other. So you can impose it on someone else. And the therapeutic relationship is what's the only kind of thing to think about in terms of treatment, because these people don't tend to go unless they're court ordered or their family encourages them to. Okay, so to briefly overview, pretty quickly, somatic symptom disorder. It's when there's one or more symptoms that are causing distress and disrupting daily life, and it involves excessive thoughts, feelings, and behaviors related to the somatic symptom. So it could be headaches, it could be nausea, and it's disruptive. But it's not hypochondria, like a preoccupation, I'm afraid I'm sick. It's more like, oh my God, I'm getting these headaches, I feel so ill. And it's persistent. So this tends to average over 6 months. And the reactions, you can specify what the particular reaction is. So like high anxiety about health, excessive time and energy devoted to health, and the predominant pain specifier is really important to remember. So there's a couple things to say in terms of interventions. According to the ATABS materials, there's not been a specific intervention that's been established as effective. However, an eclectic approach that emphasizes the alliance, psychoeducation about the disorder, and consistent reassurance has been useful for many individuals, and that's according to Yetzi in 2004. In addition, having a single physician act as the primary caregiver is beneficial. Sometimes an SSRI can reduce the symptom preoccupation and the coexisting depression and anxiety. CBT can sometimes be useful to reduce the somatic complaints and medical costs as well. So all that said, when we're talking about somatic symptom disorder with predominant pain, then there are some things that have been found specifically to be helpful, and we're going to talk a little more about that now. So with predominant pain, you want to look at, for chronic headaches, CBT. For rheumatic pain and fibromyalgia, multi-component CBT. So you're noticing a theme here. For chronic lower back pain, behavioral and CBT therapy. And in addition, with pain, acceptance and commitment therapy can be helpful, as well as just the psycho-ed and learning to relax, because there's certainly a lot of anxiety that happens about the somatic symptoms. So you want to help them learn to relax their body and their mind. And really important to refer for the medical evaluation. One important key thing to think about on the test. Think about if there's any substance abuse, if they come in talking about taking Vicodin and all of that. You just want to see if there might be some malingering in terms of drug abuse. Additionally, you can refer them to pain management programs, mindfulness-based, and some physical therapy and reconditioning, so actually working with their body to strengthen it. Acceptance and commitment therapy is highly associated with the predominant pain, and what you do is you're kind of looking at the intersection between inactivity, confused values, attachment, cognitive fusion, experiential avoidance, and dominance of conceptualized past and feared future. So all of these things are coming together to create a psychological rigidity, and you want to work through some of that. So for some reason that is considered helpful in particular. Feeding and eating disorders include anorexia and bulimia.
Low weight, less than minimally normal. Well, that's subjective.
Okay, so now we're entering kind of a big topic, which is treating anorexia. It's a very complex, difficult to treat disorder, and you'll notice that it's also in the crisis section because of the medical aspects of this. The treatment can be both inpatient and or outpatient, but in either case, it's an interdisciplinary approach that's necessary. And that means there's a psychologist, a psychiatrist, a physician, someone with food, like a nutritionist, a social worker, and other professionals. So your goal here with with any of the eating disorders, is to help the client recognize the inappropriateness of weight, goal, and eating strategies, help them verbalize it, explore it, and you want to restore normal eating patterns. There are underlying issues often, and so you want to deal with those and with shame, self-esteem, etc. And then on a physical level, you really do need the client to restore a normal body weight, which also means a more realistic body appraisal, because it's very dangerous. So let's talk about what those interventions are to achieve those goals. Inpatient treatment, that's not exactly the intervention itself, but you do want to think carefully when it's anorexia about inpatient and or outpatient treatment. The main interventions that you'll see used there, and taking already as an assumption that it's interdisciplinary approach, is cognitive behavioral, family-based depending on their age, so if they're an adolescent and still living with the family, and then coping skills to alleviate anxiety and provide a healthy sense of self-control, because there is a preoccupation that can happen around control. How do you know that it should be inpatient care? That's a really important question to be able to answer for the test. If someone's 20 to 25% below normal weight, they're really not safe. If they don't recognize that there's a problem, that's also dangerous. If they don't, and if the patient themselves, maybe they want to get better, but they really don't think they can as an outpatient on their own, that's another reason. And finally, if you have an adolescent who's in a really dysfunctional family that's either not supportive of the treatment goals or really exacerbating the problem, they're not really going to be able to deal with it while they're still in that situation. In terms of CBT, Garner and colleagues focused on beliefs about food, weight, and consequences of eating in terms of the therapy. And the stages of the cognitive behavioral therapy with anorexia is, first of all, getting the alliance and motivation. And that's huge to actually get the motivation. Once the motivation alliance are there, which is hard work, you want to deal with the behavior and normalize eating and weight. Then you can kind of move deeper into actually making it sustainable. This happens at the same time as normalizing eating and weight, of course, but as you get more stable, you're really going to start to identify and modify the beliefs with Socratic questioning and cognitive techniques. And hopefully at that point, there's a sense of understanding of what it's about, a sense of desire to stay healthy and a healthy body, at which point you'll start preparing for termination and really making sure that you address how to have relapse prevention. All that said, SSRIs can help reduce relapse and treat depression. But sometimes there can be OCD after the weight gain, and part of the belief there is that perhaps there are already elevated levels of serotonin with anorexia, and the not eating was a way of reducing serotonin levels. So Minuchin talks about treating anorexia through his structural approach. And he thinks of it as, or in this, I'm sure there's a lot of people now who have taken that on, but that there's an inflexible family structure. And so in order to really help the client with anorexia, you need to help the structure or the family restructure themselves, which means working with them in the here and now and looking at where the power hierarchies are. Look where there are overly rigid or too diffuse boundaries. And so you as a therapist are going to sit there and blend, you're going to join the family, you're going to blend with them, track them. The therapist also evaluates family, constructs a family map, and then ultimately restructures, unbalances the homeostasis, and reframes things. Just recognizing that when it comes down to it, with Minuchin's approach, the family is an interrelated system, and it's all about hierarchy and boundaries. Key concepts. Anything else to know about that? I guess you just want to know that there's a restructuring in the family, so it's better able to adapt to stress and kind of dealing with any sort of inflexibility or diffusion. I think that's about all you need to know for anorexia and Minuchin's structural family approach.
4, we had non-per.
So treating bulimia is distinct from anorexia, and so what Sharon Jablon from Psych Prep would say is that there's similar goals, right? So recognizing the inappropriateness of beliefs and eating strategies, verbalizing things, restoring normal, dealing with the underlying issues, and assessing for comorbid disorders. So that's all similar. And again, you will see CBT and nutritional counseling, as well as not necessarily the same, but maybe some pharmacotherapy. But other than that, there are different things to think about. So first of all, bulimia is ordinarily delivered in an outpatient setting unless the symptoms are really severe and disabling or include medical complications. Whereas anorexia, you'll see there's a higher, as it really gets to the severe cases, it's very dangerous and there's death. So that's one difference. If you were to name off the top of your head the top 4 ways of addressing bulimia, what would it be? So first, CBT. Second, pharmacotherapy is often the case. Mild depression, it's not, but a lot of times it is. So what are the other 2? The other one that is unique is interpersonal psychotherapy, which you'll notice is often used with depression. And the focus is identifying and resolving whatever the interpersonal context is that's maintaining their maladaptive eating behaviors. So this is based on a particular assumption about bulimia, that handling of interpersonal relationships, like faulty handling of them, is causing emotional upset, and then combined with chronic dieting, triggers a binge. So then, of course, there's going to also be nutritional counseling to help correct maladaptive beliefs and replace unhealthy patterns. And you want to, so those are the 4, CBT, interpersonal, nutritional, and psychopharm. In terms of interventions, you also just want to think that you're giving this person coping skills to alleviate anxiety and help provide a healthy sense of self-control. Because bulimia and anorexia have a lot of issues around feeling like there's a healthy control. Referrals and adjuncts, of course, psychiatrists, of course, medical evaluation, and certainly nutritional here. In addition, you do want to consider inpatient hospitalization. It is not as common as with anorexia, but you do need to consider it. There can be serious medical complications. And then building on that, you want to have them have a dental evaluation, because with purging, there can be a lot of erosion of the teeth, and self-help groups. So groups can be helpful here. With anorexia, you're thinking more family therapy. With bulimia, you're thinking more self-help group. Self-reinforcement. Self-reinforcement is when you are administering the reinforcement to yourself. So this is something kids do for sure, but I think it especially brings up the image of adults who are trying to do weight loss or trying to lose weight, and they monitor themselves using records. There's apps on the phone now, and they start to also control their environment stimulus that they encounter to narrow the range of responses. So 2 self-management procedures is just self-monitoring and stimulus control. Those are the two pieces to really know. Self-monitoring is what you usually do initially, and this is done with CBT a lot. You're recording things, getting information about the nature and magnitude of the behavior, and that also can help you develop what your treatment is going to be before you kind of move on to stimulus control and all of that kind of stuff. Stimulus control basically means that your behavior is under stimulus control when doing it is contingent on the presence of something else. So, cigarette smoking is contingent or controlled by things like drinking coffee, talking with friends, being alone, or having a pack of cigarettes. So when you want to use a stimulus control technique, you're altering your associations between the stimulus and the behavior. So narrowing is restricting the target behavior to a limited set of stimuli. So you can only smoke at 5 p.m. after work. That's not a great one, because usually people who are smoking are trying to get rid of it altogether. But let's say with trying to lose weight, you only eat at meal times. You're not snacking and running into the kitchen and putting your hand in the bag of chips all the time. Cue strengthening. That's when you link a behavior to specific environmental conditions.
Eating means sitting at the table. Sitting at the table. Studying, if you want to increase something like studying, then you cue strengthen. So when you go to your desk in the office, you study. So cue strengthening is more about increasing this particular behavior. Narrowing is usually restricting the target behavior to a limited set of stimuli. And fading consists of changing the stimulus conditions associated with the behavior. So this might be when a cat is trying to chew on your hand, you put a cat toy in their mouth. And this could also work if you have fetish objects. Give them something more appropriate.
Elimination disorders are enuresis and encopresis. Enuresis is voiding of urine into the bed. This needs to be, criteria is twice a week for 3 months. There are specifiers of nocturnal, diurnal, or both. You need to be at least 5 years of age because otherwise it could just be part of development. The treatment is bell and pad, which is basically an alarm that wakes the person up, and that's found to be effective in 80% of cases. Additionally, imipramine can suppress it, but most people relapse because there hasn't actually been treatment. An antidiuretic can also be helpful for a short period of time. Encopresis is the involuntary or intentional passage of feces into inappropriate places. This has to be once a month for 3 months. So this can happen much less frequently and still be considered a disorder. So we'll talk about treating enuresis, and what would you guess, since it's very specific, what would you suggest is the primary intervention? So behavior modification ends up being the primary intervention. All that said, when you think about it from the kind of one step before that, which is what is your actual goal, first of all, you want to decrease punitive and hostile reactions from the family and shame around it. You want to evaluate for comorbid problems like depression or some stressors, because sometimes these disorders are secondary to something else. And of course, you want to reduce symptoms, which means eliminating the episodes of enuresis or encopresis, as it might be. And then you want to resolve underlying conflict. So what do you think? You think decrease punishment, evaluate for comorbid problems, and then deal with any sort of stressors or underlying issues. Interventions it actually has its own name, behavior modification for enuresis. We'll talk more about that, but the second part, so there's both a urine alarm and parent education. So we'll talk about the parent education first, and that's saying don't ridicule in response, and you want to actually establish a reward system for the continence. So how does the alarm work? Basically, you have an alarm that goes off. It's usually called bell and pad if there's a nocturnal, peeing enuresis. The effectiveness is improved when it's combined with behavior rehearsal or overcorrection. So you want to give them bladder training. So practice delaying bladder emptying, interrupting the stream during urination, and implement dry bed techniques. So there's a lot of different things you can do. Response inhibition, positive reinforcement, rapid awakening, and really decrease critical comments because it doesn't help. And it makes them feel worse. One last thing to say about that is drink less water before bed. I do want to add that it's important there's 2 really important pieces here to think of and address. First, important is to have a medical evaluation because this is kind of a medical thing. And secondly, you do want to think about if there's child abuse. It's not always the case, of course, but it can be a reaction to so much stress and abuse. So just have that on your radar. So the drug that they use to suppress enuresis is called imipramine, and it suppresses the frequency of bedwetting. However, once the drug is discontinued, most will relapse within 3 months. So it's an anticholinergic, by the way. So you want to really, if you have parents who are on board, it's a lot better if you can actually do the behavior modification and really take away any shame about it. That's important for their psychological health. Sleep-wake disorders. We will just briefly talk about of these: insomnia and narcolepsy, and also non-rapid eye movement. But insomnia disorder is just, it requires somebody to be dissatisfied with the quality or quantity of their sleep. This needs to be 3 nights a week for 3 months. So 3 nights a week for 3 months, which is, almost half the time you're struggling. One symptom, one symptom of this, like initiating sleep, waking up too early, all of these things. Treatment incorporates strategies like sleep hygiene, education, and stimulus control. Hypersomnolence is excessive sleepiness despite sleeping enough. Narcolepsy, this is also 3 times a week for 3 months. There are like daytime naps or just lapsing into sleep accidentally. It also requires the presence of cataplexy or REM latency, which is less than 15 minutes. Finally, non-rapid eye movement disorder. This is different than nightmare disorder. The essential features is that there's an incomplete awakening during the night, and it's the first third of the sleep episode. It can involve sleepwalking, sleep terrors, but the thing about this is that there's limited or no recall of it even happening. Whereas with nightmare disorder, the dreams are very well remembered, and they're fully awake and afraid when they wake. So how do you treat sleep disorders? So I am going to name a number of interventions, but see if you can first name 4 treatments that you would use. So first up would be sleep hygiene education. That's huge. Second is stimulus control. Third is relaxation training. And 4th is cognitive therapy. So as you go through your treatment planning process, right, you're going to do some case conceptualization, see what's going on, and then you want to establish objectives and goals with your client. So what are objectives and goals you want to think through when you see sleep disorders? First of all, you want to improve their ability to fall asleep and improve their ability to return to sleep and restore a restful sleep pattern. So actually pretty clear. You need to clarify when you're doing your case conceptualization whether the sleep disorder is related to a mental condition like depression, a medical condition, or substance abuse. And then you want to decrease the secondary or anticipatory sleep problems that have arisen from the disorder. So like avoidance of going to bed, worrying about it. And if you see sleep disorder on the test, then you do want to think about potential substance abuse, because there can be a lot of sleep disturbance with substance use. So what will you do? Per usual, you're going to make a medical evaluation, psychiatric evaluation. The medical evaluation is probably going to be at a sleep lab where they'll have a sleep study. And if you can assess a little further, you can see if it's appropriate to also give a substance use evaluation and treatment. Interventions, cognitive behavioral therapy, sleep restriction therapy, stimulus control, relaxation training, paradoxical intention, EMG biofeedback. And then you need to, of course, treat any mental disorder that is contributing to the problem. So CBT makes sense. Stimulus control, I think, makes sense. So that means like turning off the TV, like, only being in your bed when it's time to go to bed. Paradoxical intention and sleep restriction therapy are kind of unique to this disorder compared to other of the disorders we've talked about here in this section. Now we're moving into sex, gender,
impulse, conduct, substance.
So what are the 3 sexual dysfunctions that you're most likely to see in your practice? The first is erectile disorder. The second is genitopelvic pain penetration disorder. And the third is premature ejaculation. So let's talk about what each of those are. Erectile disorder is a marked difficulty in obtaining an erection during sex, maintaining it, or losing it at the end. And it happens on almost all occasions, and you need to remember that it's there's a 6-month, for all of these, there's a 6-month minimum that it has to have been going on. You can say how distressing it is, how long it's been, how severe it is it a generalized or situational piece. And before you assign that, you do need to rule out medical conditions and substances, because antidepressants or multiple sclerosis, there's different things that can cause it. So medical evaluation is necessary, and you're going to want to treat it with CBT and or Viagra. Genitopelvic pain or penetration disorder is the diagnosis in the presence of persistent or recurrent difficulties in one or more of the following. It could be vaginal penetration or pain, pain in penetration, intercourse, there's anxiety during, before, there's tension. And again, this has to be about 6 months and distressing. And there is research that shows it's associated with a history of sexual or physical abuse. Finally, premature or early ejaculation is that there's a recurrent pattern of ejaculation during sexual activity within about a minute of penetration and or before the person desires it. And again, 6 months and different same specifiers. So we're going to now talk about how these disorders can be treated. So sexual dysfunction treatment. There are 6 different treatments that we're going to talk about. And let's actually start not with the treatment, but start talking about what you want to do first. And what you want to do first is make your referral, if it seems appropriate, to the psychiatrist for medication evaluation and a medical evaluation to rule out medical causes. You can also, on the referral topic, refer them to sexual health clinic, bibliotherapy, and that kind of stuff too. So your goals when you're treating sexual dysfunction is there's a lot of anxiety that's been built up at this point. So you want to decrease the anxiety and achieve satisfaction and enjoyment. Again, when there's pain, of course, you want to decrease or eliminate it. And another goal that is not necessarily what the problem has been named as, but you want to enhance their ability to communicate about these sexual issues. So what are the very specific interventions? Sex therapy, that is actually CBT, but it just targets dysfunctional behaviors, the anxiety, all of that stuff, and deficits in knowledge. Sensate focus is meant to help decrease the anxiety, and you have graded exercises that you do. The start, stop, and squeeze technique is meant to increase male control over the ejaculatory reflex. Kegel exercises are meant to increase sexual pleasure. And couples therapy, which is our 5th one here, it can be really helpful because it can either be a cause of and or a symptom of issues between the couple that can be worked through that way. In terms of the drugs that the psychiatrist might provide, Viagra, of course, will increase the ability to maintain an erection, and SSRIs can actually help with premature ejaculation, which is linked to low serotonin levels. Health promotion strategies like reducing smoking, drinking, and increasing physical activity can also be helpful. That's a side note. The sexual dysfunction model is Masters and Johnson, and they see pleasure as counter-conditioning. So the sexual cycle is excitement, plateau, orgasm, and resolution. Sensate focus, we talked about, which is decreasing anxiety, graded exercises. You can see this couple is very happy here on the slides if you had the slides. Sexual dysfunction of the start, stop, squeeze technique. If you had the slides, you would have the pleasure of seeing what that actually is. And it's all about being able to increase control. And Kegel exercises, here's the instructions. Contract your pelvic floor muscles for 3 seconds, then relax for 3 seconds. Do this 10 to 15 times, several times a day. And in the picture here, it's the woman's lying down, but they can be done during a variety of daily activities, like sitting in a meeting, while stopped in your car, or at a traffic light, or when talking on the phone.
Paraphilic disorders. These are intense and persistent sexual interests that might cause harm or distress to others. That's one possibility for paraphilias.
It's become a disorder, and they have not engaged in the behavior for 5 years or more in an uncontrolled environment, then they are in full remission. So literally, they're looking at that 5-year mark, and once they hit that 5 years, then it's no longer you would do in full remission. So those are the specifiers for paraphilic disorders. Now, what are the types? These are all mentioned in the DSM-4TR, but we'll talk about them. Voyeuristic disorder, so people like to watch. Exhibitionistic disorder, people like to have others watch while they engage in some sort of sexual behavior. Frauderistic disorder, you often see that a lot in subway systems. I know in New York, you'd see it a lot where there was this, there was no consent involved. So the person rubs against or touches somebody inappropriately without consent. That is a frauderistic. So oftentimes they'll rub against another person. You see it on the subways. Like I said, it could be at a concert. It could be on a dance floor. People might do this where they literally will rub against somebody or touch them without their consent. Sexual masochism and sexual sadism. So that it involves either being sort of violated, whether it be verbal, emotional, physical, as well as being the person that violates. So there may be whips involved. There may be some sort of pain devices involved. And so, again, some people are into sadomasochism, and that is sexually related. They get pleasure off of it, sexual pleasure off of it, until it is something that causes distress or it's potential harm to themselves or another person by the fact that they haven't arranged some sort of language or the person is unable to cooperate with that, then it becomes a disorder. Pedophilic disorder, this is about prepubescent children. So pedophilic disorder, prepubescent children or around puberty, that's pedophilic disorder. Fetishistic disorder are fetishes, and there's tons of fetishes out there. Necrophilia, people who like to engage in having sex with deceased persons. Shoe fetishes, you name it, there's a fetish usually for it. So that would be a fetishistic disorder. Any type of items or dressing in a certain way. Transvestic disorder is where a heterosexual male will receive sexual gratification from either dressing in women's clothing, or it also states that having their partner or significant other or wife or whatever wearing typically masculine clothes. So they engage in activity. Either they are sexually gratified by dressing up in women's clothing and engaging in sex, or their female partner dresses up in masculine clothing or as a man or what's stereotypical of a man, and they get off on that as well. And so with transvestic disorder, it isn't about gender identity. It's purely about what is sexually gratifying to them. And so they do identify as heterosexual males. So these are the different types of paraphilic disorders. Now, moving on to substance related and addictive disorders, what they did is they actually did expand it to gambling disorders. So that was one of those disorders in DSM-4 that they had said, well,
aversive conditioning, or you can also think of it as aversive counter conditioning, is when the maladaptive behavior or stimulus, the conditioned stimulus, is paired with an unconditioned stimulus that naturally evokes pain or other unpleasant responses. So instead of just removing the whatever it was that was negative and adding something positive, you're actually taking something that has been conditioned to cause positive feelings and pairing it with something negative. So it's sort of the flip. And like with the other counter conditioning techniques, if you remember systematic desensitization, you can do this both in imagination and in vivo, in life. So when you're doing it in vivo, this is called overt sensitization. And when you're doing it in your imagination, not in life, it's called covert sensitization. So let's talk, so why is this used? These are typically used for behaviors that are deviant, paraphilias, for example, smoking, alcohol abuse. It's not going to be used with something like social anxiety, typically. In vivo is used to treat primarily drug and alcohol addiction. So paraphilias and self-injurious behaviors. So antabuse is an example of something that would be used to treat alcoholism, because when you then drink, you now have extremely unpleasant sensation and feel very sick. Eliminating a sexual fetish, whatever the object is, let's say it's a shoe, might be paired with an electric shock, so that eventually people are going to avoid, sexualizing a shoe because it produces an unpleasant sensation rather than arousal. This has been found to be moderately effective initially for some patients and some problems, like cigarette smoking. Problem is it's associated with high relapse rates and limited generalizability. So it's most successful when the aversive stimulus and its consequence is similar to the target behavior. Like nausea-inducing drugs are more effective than electric shock for treating alcoholism, and stale cigarette smoke and rapid smoking are more useful for reducing smoking than, again, an electric shock. It's also more effective when it's supplemented by booster sessions or is administered in conjunction with other treatments. And I think particularly it's worth thinking about this in terms of paraphilias, treated by combining aversion therapy with orgasmic reconditioning, relapse prevention, and other techniques that help strengthen more appropriate responses. Because this is a pretty serious problem, and whereas this might be a technique that's helpful, it's not enough, and it needs to, since aversive conditioning is sometimes thought to actually be suppressing some learning, not really getting rid of it, then you need to make sure that you continue over time to give this treatment if necessary. Covert sensitization and imagination. You want to eliminate the behavior by imagining yourself smoking. So instead of actually rapidly smoking a cigarette, you imagine yourself smoking a cigarette, and then you imagine yourself becoming nauseated, throwing up on yourself, being embarrassed, all sorts of negative things. And to help establish an alternate behavior, the therapist might also have the client envision a relief scene in which they choose not to have that cigarette on a break. They're sitting on a bench and they're just breathing the fresh air and enjoying themselves. So pleasant sensations are now associated to supplement it.
Impulse control and conduct disorders. So this section combines these following ODD or these following disorders, such as oppositional defiant disorder or ODD, conduct disorder, disruptive behavior disorder, NOS, intermittent explosive disorder, pyromania, and kleptomania. So, starting off with oppositional defiant disorder, what we have in the new DSM, so DSM-5, what they've done is they've categorized three major sort of categories of symptoms. So, for example, the person in at least 6 months, so the 6-month criteria remains the same. They have to have at least 4 symptoms, and it could be from any of the categories that I list. So the first category is angry or irritable mood. So from that category, we have often loses temper, is often touchy or easily annoyed, is often angry and resentful. Now, for the argumentative, defiant behavior category, we have often argues with authority figures, often actively defies or refuses to comply with requests from authority figures or with rules, often deliberately annoys others, often blames others for his or her mistakes or misbehavior. So that will be category 2. Now, with category 3, this is vindictiveness. So, with vindictiveness, the person has been spiteful or vindictive at least twice within the past 6 months. So, it doesn't matter where or what category you take these symptoms from. What matters is the person has at least 4 symptoms. If they have 4 symptoms, then it's going to be categorized as ODD, or they meet the criteria for ODD. Now, what they did with specifiers, so in DSM-4, what they said is it really should be 2 or more settings, but what happened here is that they found that it would happen in 1 setting. So how their specifiers are for severity depend on the number of settings that this exists in. So if they have any of these within 1 setting, that's mild. 2 settings, so say now it's home and school, moderate. Now let's say it's home, school, and maybe work. Because again, ODD can be diagnosed now in adulthood. So maybe it's in 3 or more settings, and one of those settings is at work. Then it's severe. So again, the specifiers of ODD would be mild 1 setting, moderate 2 settings, severe 3 or more settings. So that is ODD. The next one that we want to take a look at is intermittent explosive disorder. Well, in DSM-4 TR, what they said is that it required physical aggression. So it required that for a diagnosis of intermittent explosive disorder, the person had to be physically aggressive. But the situation is this. Now, in DSM-5, they say it could be verbal aggression, non-destructive and non-injurious physical aggression, and it also could include destructive and injurious physical aggression. So it doesn't have to be just physical aggression. It could be just verbal aggression. So that's the big change in intermittent explosive disorder. The only other criteria is that the child must be at least 6 years of age. Now let's look at conduct disorder. So in DSM-4, we remember conduct disorder looking like they had to have met criteria for at least 1 of 4 categories, and they listed those categories: aggression to people and or animals, destruction of property, deceitfulness or theft, severe violation of rules. Well, they've kind of kept those subheadings, but what they said is that they must only meet criteria for 3 of 15. So they specifically put specific symptoms under each category. And if they have 3 of those 15 criteria in 12 months, then they meet criteria. Now, the other piece is that they have to have at least one of these symptoms in the past 6 months. So if everything happened 9 months ago and there hasn't been anything in the past 6 months, you cannot diagnose conduct disorder. But if they've had at least one or more symptoms in the past 6 months, and then plus the rest of them later, within a year, then you have conduct disorder. So what are they? So the first category is aggression to people and animals. So specifically under there, they say they often bully or threaten or intimidate others. They often initiate physical fights. They have used a weapon that can cause serious physical harm to others. So a bat, a brick, a broken bottle, a knife, a gun, some sort of weapon that could, seriously harm somebody else. Has been physically cruel to people, has been physically cruel to animals, has stolen while confronting a victim, so mugging, purse snatching, extortion, armed robbery. And then the 7th one under that is has forced someone into sexual activity. So all of that would fall under aggression to people and animals. Now the second section is destruction of property. So with destruction of property, the 2 symptoms that are listed under there, which are 8 and 9, are has deliberately engaged in fire setting with the intention of causing serious damage. Now, if you had this on its own, it would be pyromania. So we'll talk about that in a few minutes. But this falls under destruction of property right now, has deliberately engaged in fire setting with the intention of causing serious damage. The 9th symptom has deliberately destroyed other property. And this is by other than fire setting, because the one previous to it is fire setting. The 3rd category is deceitfulness or theft. So symptom 10 would be has broken into someone else's house, building, or car. 11, often lies to obtain goods or favors to avoid obligations. So they're like con artists or they con others. 12 has stolen items of non-trivial value without confronting a victim. So shoplifting, but without breaking and entering or forgery, because that would go into your first category. Now, the last category, which is category 4, is serious violation of rules. Symptom 13 says, often stays out at night despite parental prohibitions, beginning before age 13. So it had to have started before the age of 13. Number 14, has run away from home overnight at least twice while living in the parental or parental's surrogate home, or once without returning for a lengthy period. 15 is often truant from school, beginning before the age of 13. So really, they're looking at 3 of these 15 criteria in the past 12 months. Now, what they're saying is if the person, because now we're on a lifespan, so if the person is 18 years or older, you want to look and make sure they don't meet criteria for antisocial personality disorder, because then if they do, it wouldn't be conduct, it would be antisocial personality disorder. Okay? Now, many people before would say, I know conduct disorder as being like antisocial, and it's kind of a pre-antisocial, which isn't the case, but previously they said you had to meet criteria for conduct before antisocial, and one of those reasons is because of the lack of prosocial emotion. So they often said that conduct kids lacked remorse or guilt, they often lacked empathy, they were unconcerned about their performance. So what they did now is they found that there are kids with conduct disorder that actually do have remorse, that do have empathy, that do sort of have that guilt about what they've done. And so what you would do is, in the instances that they do not, so they have limited prosocial emotions, then you would specify it conduct disorder with limited prosocial emotions. Well, what is the criteria in order to become or have limited prosocial emotions? You must have two of the following symptoms persistently in the past 12 months or the past year. One, lack of remorse or guilt. Two, that callousness, that lack of empathy. Three, they're concerned about performance. Some people ask me, well, what does that mean? Well, they may say, I don't care about this schoolwork. I don't care if I'm getting an F. It means nothing to me. I don't care if I just got fired. So unconcerned about performance and the shallow or deficient affect. So if they have two persistently of these four symptoms over the past 12 months, at least two of these, then you can specify with limited prosocial emotions. So otherwise, if they don't meet this criteria, then it's just a pure conduct disorder, and we know that they're exhibiting these four things. They have guilt, they have remorse, they have empathy, they are concerned about their future, they do have some sort of affect. Pyromania. With pyromania, this is deliberate and purposeful fire setting on more than one occasion. And what usually happens with these individuals is that there's some sort of tension or affective arousal before that act happens. They also seem to have a fascination with, or are interested in, or curious about, or attracted to the fire and what happens based on the fire. And of course, you have to rule out fire setting is not done for monetary gain. So some people will burn down buildings, will burn down houses because of insurance purposes. So you have to rule that out, and it's not included in the diagnosis of pyromania. So here, I love showing pictures here. So what else happens with pyromania is that the person has pleasure or gratification, or there's some sort of that tension that they feel is relieved once they set the fires or they witness or participate in the fires. And so here we have a great girl, little girl, she has that affect that's like, don't mess with me. And that's because her neighbor had a bigger teddy than her, and she says, Pat. So she burnt the place down. That's the perception of the picture. That's kind of what happens. So they have some sort of pleasure or gratification or relief when setting these fires or witnessing or participating in fire setting. Now, kleptomania is the same exact thing. Same exact thing as pyromania, except it has to do with the impulse to steal. So these individuals cannot resist the impulse to steal. It doesn't matter how much money. We've seen celebrities, people who are billionaires, that exhibit kleptomania, and there's just this sense of tension that they have to like steal something, and they get pleasure, they get gratification, or they get relief at the time or thereafter of stealing. And so it's the same thing as pyromania, but it is in fact kleptomania, which is stealing.
Okay, so oppositional defiant disorder. This is characterized by a recurrent pattern of just being angry, irritable, argumentative, and defiant. There's some vindictiveness, but it's really kind of conflict with authority, and it has to have been happening for over 6 months. So could you name a couple other disorders similar? So one would be generalized anxiety. And when you see the oppositional defiant client, you start with your case conceptualization. So what are you going to do there? You want to assess for comorbid disorders, particularly learning disorders, depression, and a history of abuse. So that's your case conceptualization piece. Another thing is ADHD is often comorbid, and this can precede conduct disorder. So you do want to make that differentiation. However, conduct disorders involves a lot more of a serious violation of basic rights. You want to also think about substance use because there is an increased risk for both anxiety, depression, and substance use here. So what are your goals of treatment? You want to help the patient recognize the inappropriateness of their action. If you said it that way, I don't think you'd get a buy-in from an adolescent, but but also, help them link it to the negative consequences for them. Part of this can be if you're feeling irritable and aggressive, there might not be a lot of coping skills. So you want to teach coping skills like relaxation, assertiveness, anger management, and then they can develop alternatives to the like angry outbursts. Like they have more options for themselves for when that isn't what they would want to choose. If there's any behavior that's antisocial, illegal, cruel toward animals, now that's conduct disorder. Okay, so I'm talking about both, I guess. So you don't need to worry about that, but you do want to help them decrease oppositional behavior. Now, if it were me, some oppositional behavior is very healthy, so I probably wouldn't want to have them get rid of all of it. But yeah, just to remember that this is not the cruel, antisocial, illegal stuff is more the conduct disorder, not oppositional defiant. And it's more like they're losing their temper a lot. They're annoying people purposely, that kind of stuff. Interventions, the interventions for oppositional defiant and conduct are similar, so I'm going to go on and talk about conduct disorder, and then you'll hear more about the interventions then. So conduct disorder, know that conduct disorder means you have 3 symptoms from 4 categories, including aggression, destruction of property, deceitfulness, and serious violation of the rules. The duration needs to have been over a year and included 3 or more of the symptoms. The onset is during childhood. You can't diagnose it after 18 if they meet the criteria for antisocial. Often comorbid with ADHD, ODD, learning disorders, depressive, bipolar, anxiety, and substance disorders. The interventions are multiple, but the first thing to remember is family and actually multi-systemic. So it's really useful, especially for youth and adolescents, to have out-of-home placement if they've been at risk, and just a lot of support, academic, social skills. This is really something that needs to happen on all fronts. Parents need to be trained to replace any sort of coercive or negative inconsistent discipline, and that is functional family therapy is often used to help with those interactions, starting with engagement, behavior change, and then generalization finally. In terms of the patient themselves, cognitive problem-solving skills training, help them figure out new ways to solve their problems versus just going to violence. And then pharmacotherapy is not generally recommended. However, that can be used if the behavioral problems are escalating and they're really posing a risk of danger. If this person wants to change and they can't, or they have ADHD, it might be useful. And then the final thing that we just mentioned briefly is sometimes out-of-home placement is really important. Because if there's severe family dysfunction, it's really not going to work. And you can see homicidality and suicidality sometimes too. Okay, we're talking about treating conduct disorder, and just thinking this is also for oppositional defiant. So while they are, while oppositional defiant can precede conduct disorder, and while conduct is a more serious disorder, that doesn't mean that there isn't a similar way of dealing with them. So we've talked about our goals. So help them recognize that it's inappropriate, the consequences, help them with better coping skills, more alternatives to how to respond to things. And the goals of treatment are also to decrease some of the, especially with conduct disorder, basic violations of rights and all of that. So what do? This is one of those cases where you want to really be thinking in terms of the multi-systemic therapy. I think I might have actually just had that on the other slide, so I won't go too deep in then. I'll kind of move it along. But you want to actually take a moment to think to yourself, if you just heard about all of this, what would you say the 5 different pieces that you need to think about are. So, family intervention. You want to set rules, negotiate, reward the positive, replace physical punishment. You want to do cognitive problem-solving skills training, so that's the replacing training, coping skills. You want to do multi-systemic therapy. Yeah, we did talk about this. So you want to do multi-systemic. You want to have all sorts of folks working on this together. You want better boundaries for the kids, not in a rigid kind of dominating way, but you want good boundaries with them. There does need to be some rigidity, actually. Sometimes going away to like boot camps can be helpful. Pharmacotherapy is actually not generally recommended, and this is one of those few cases where you won't see that. But maybe when there's a high risk for danger, or they're not going to be able to change until like depression or something else like that is addressed. Also thinking about out-of-home placement. If you have conduct disorder or really severe family dysfunction, sometimes it's necessary to be out of home before any progress can be made. And there can be risk of suicide, homicide, given severe impairment due to substances and mood disorders. So you might have to hospitalize at some point. So make sure that you do what referrals would you say? First of all, psychiatric for the med-eval, but you also want to think about residential treatment and substance use evaluation and treatment, and fourth, legal consultation, because if we're talking conduct disorder, we are probably talking about legal issues as well. Here's your key terms: positive reinforcement, thinning satiation, prompts fading, shaping versus training, the Premack principle, differential reinforcement, punishment habituation, overcorrection, response cost, timeout, and functional behavioral assessment. Remember the 4 quadrants of reinforcement punishment, and then also positive negative from learning theory. Positive means you add something, negative means you take it away. If you're reinforcing something, you want to increase that target behavior. If you're punishing something, you want to decrease that target behavior. So think about that when you look at the exam questions of what exactly the target behavior was, because it can trip you up a little bit if you don't pay attention. Factors that influence punishment: the sooner the better. Be a consistent, continuous schedule. Moderate intensity. If it's too strong, you're not going to get what you want. Avoidance, or you could even get angry, acting out even further. You don't want to do gradual increasing of the punishment, because then people can get habituated and it's not effective. Similar to reinforcement, verbally clarifying. The effect is maximized when that contingent relationship is made really clear verbally. Remove all positive reinforcement. Well, punishment's going to work best when you're only getting punished, you're not getting reinforced as well. So make sure that that is also withheld. Reinforcement for alternate behavior. So this could be in your differential reinforcement category. But because punishment's teaching a person what not to do, it really is more effective if you can also combine it with reinforcement for what to do. It's important to determine if that undesirable behavior is actually just because the person has inadequate skills. Because if you punish someone and they don't really know what else to do, then they need to get trained in those skills before the punishment's going to have any sort of really great effect. So overall, if we think about this, the use of punishment is mixed for a number of reasons. It's been criticized for ethical, legal, and practical reasons. For ethical reasons, some authorities consider punishment and other aversive techniques to be always unethical, but some think, you know what, if no other treatments are effective and the target behavior is really harmful, then it might be better to punish than let them keep going if it's really your only option. If someone's going to kill themselves with alcohol use, if someone is molesting children, these are cases where maybe the punishment not necessarily fits the crime, but punishment is better for fixing the crime. Also, in terms of practical considerations, you have to keep in mind that it really is suppressing a behavior and not eliminating it. So if a person learns when that punishment is going to occur and then engages in the behavior when when it's going to incur, then that's unlikely, but they might go do it some other time. Punishment's also associated with several negative side effects, including fear of the punishing agent and increases in aggressiveness, negative emotions, escape, because this person is getting when you are punished in life, that has impacts on you socially and emotionally, how you feel about yourself, how you feel about the world. So it's a little bit more complicated than, yay, reinforce, yay, punish. There's other things that you touch when you're reinforcing and punishing. And punishment, the negative effects of punishment really highlights that. Let's talk about types of punishment. Verbal reprimands, overcorrection, negative practice, and response cost, as well as timeout reinforcement. So let's go through these pretty quickly. Verbal reprimands. What might be a way you'd reprimand someone? Say no, say stop. This is meant to suppress unwanted behaviors in a variety of settings, but it's kind of inconsistent because reprimands can act as positive reinforcers and actually increase behavior sometimes. So if you're a kid who's not getting a lot of attention, then your mom yelling at you might not be the best kind of attention, but it's attention. Reprimands are also probably only going to cause temporary impact. You need to back it up with other things. Overcorrection is a form of positive punishment when the punishment, you're going to have to do something or something's getting added. And it can involve either one of two things. Restitution is the first, and that means that you have the individual correct any negative effects of their behavior. And positive practice requires the person to practice more appropriate behaviors, usually in an exaggerated fashion. Overcorrection often involves providing verbal instructions, and it might require constant supervision or manual guidance through the corrective behaviors, which can be problematic because that can also illustrate avoidant aggressive behaviors in themselves. So in this picture, you see a little kid giving her a massage. Well, maybe they were screaming and running around the kitchen and driving her absolutely batty, and she said, if you don't stop, then you got to give your mom a foot massage. So in some ways, this is an overcorrection, because let's say stress was what they were causing their mom. Well, they have to sort of make reparations for that behavior, and they are certainly there's a manual element to that there. So there's a restitution here. They're correcting the negative effects. And positive practice of practicing more appropriate behaviors. Well, maybe this isn't something they should be doing with their mom all the time, but it is maybe a little bit more appropriate to the mom than yelling and screaming is. Fox and Azrin treated a hospitalized woman with severe retardation who constantly disrupted the ward by throwing things and overturning her bed. So when the woman engaged in this behavior, what they did was required her to straighten the entire room, which is restitution, and then to practice more desirable behaviors, such as making up all the beds on the ward. So maybe with these kids, they had to say sorry to their mom. That was part of the restitution before they had the overcorrection piece, which is like giving mom a foot rub is definitely above and beyond, but hopefully helpful in learning and fun for mom. Negative practice is essentially the opposite of the positive practice component of overcorrection, and it involves requiring the individual to deliberately repeat the undesirable behavior to the point that it becomes aversive to the individual or the person is fatigued. It's especially useful for eliminating habits and other behaviors that they'd like to eliminate, like nail biting, hair twisting, pickup, motor tics, stuttering, smoking. So, as an example, when used to eliminate a motor tic, you are supposed to practice your tic rather than trying to suppress it. And then when it does occur, you repeat it for a specified period of time, so you get really sick of it, hopefully. Response cost is an application of negative punishment, and it involves removing a specific reinforcer every time the target behavior is performed. Although response cost is most commonly associated with token economies, you lose your tokens, it can be used whenever the control of positive reinforcers is possible. So a parent can use it to reduce the misbehavior of their child by taking away their computer privileges for a specified period of time, or you could decrease the allowance every time the child engages that behavior. Other examples are fines for traffic violations and late fees for paying credit card bills after the due date. Timeout is our final one. This involves removing all sources of positive reinforcement for a brief, pre-specified period of time. teacher could do that to eliminate disruptive behaviors. Have a little part of the corner where you sit for 5 minutes. And it's usually classified as type negative punishment, but it's also considered to be a form of extinction. However, note that extinction entails continuous removal of a reinforcer from a previously reinforced response, while timeout involves removing all reinforcement for a specified period following a behavior that may or may not have been established or maintained by reinforcement. We don't know. An evaluation of timeout. Some research suggests the duration really doesn't matter. Short timeouts are effective, and longer ones are effective as longer ones. The optimal is considered to be 5 to 10 minutes. Like other forms of punishment, timeout's most effective when combined with reinforcement for alternative behaviors. So if timeout begins with a brief explanation of why it is being applied. That's a verbal clarification as well. And is there any, if you want to differentially reinforce, or not differentially reinforce, but if you wanted to add something, a positive behavior, you could teach the child to meditate when they're sitting there. That's probably not going to go great with a little kid, but maybe if you have a teenager who loves Buddhism, who's somehow getting timeouts, that would be an example. So, first of all, the diagnostic criteria, you try to cut down, you can't. You crave the substance. It's causing problems in your life. You're even in physical dangerous. And when you try to stop, there's actual physical signs. So this is a substance use disorder. The 4 categories that it's really talking about is issues of control, social issues, risky behaviors, and buildup of tolerance. So what about relapse, which is the essential piece here? There's Marlott and Gordon relapse prevention therapy. And this is really important because it's different than AA. It says, look, drinking is an overlearned maladaptive pattern. And relapse is going to happen. You know, maybe it won't, but it makes sense that it would happen. And that's okay because it's just a mistake. And it results from things that are external that you can control. So you use CBT strategies then to prevent those yourself from being in situations where those external factors will trigger it. Then talking about tobacco use disorder and smoking cessation. So people don't always want to quit because they're afraid of gaining weight, particularly with women. They're afraid of failing. And it's really hard to do. So things that are associated with people that are successful is, for example, men that are older than 35. Smoking cessation treatment. This includes 3 different pieces: nicotine replacement, multi-component behavioral therapy, and clinician support. Okay, we're going to talk about substance-related and addictive disorders. So what is substance use disorder? This has been a change from the DSM-IV. When you want to diagnose substance use, you need to have 2 or more symptoms that have gone for 12 or more months. And they happen in a cluster of cognitive, behavioral, and physiological categories. But what the crux of it is the person's continuing to use a substance despite significant problems. You can specify here whether it's in remission, early, sustained, or if they're in a controlled environment. So maybe they're not drinking, but it's also because they're at a facility, and the level of severity. There are different symptoms that have to do with how much control the person has, their social impairment, any risky use, and then the pharmacological piece of like tolerance, withdrawal, and cravings. So we're going to talk more about the treatment, but let's do the really quick overview here that first you want to use motivational interviewing and motivational enhancement therapy to increase the actual desire to address the issue because that's not always there. You want to think about contingency management and multidimensional family therapy. And then finally, you need to, as you have made some progress, you need to think about skills training and relapse prevention so that they have skills where they don't need to go to the substance to deal with their anxiety or whatever it might be that is stressful for them. Medication management can help whatever, because there can be symptoms that were being masked by the substance use. What referrals would you want to make? 12-step programs. The test will is positive toward those. And medical evaluation treatment, of course, psychiatrist, or medical and psychiatric evaluations. And then you need to think about neuropsychology because of damage that could be done over time with severe substance use problems. Inpatient, and then you need to decide, you don't decide, but thinking inpatient detox, long-term residential, sober living home, what is going to be the best context to deal with this? Vocational rehab, a lot of just destruction can be brought onto one's life. So using social services and vocational rehab to kind of rebuild is also useful. So substance-induced disorder, basically, it's another disorder. It's a clinically symptomatic presentation of a mental disorder, but it developed within a month of a substance use withdrawal, and you really can't explain it any other way. So delirium, we already know, is a result of withdrawal. So we're not talking about that, but it could be other things. And there needs to have been intoxication and or withdrawal to actually make this diagnosis. What's the duration onset? Well, in general, it needs to be within 1 month of the intoxication withdrawal. For alcohol-induced, the withdrawal is going to happen within a few days, and 2 or more symptoms within a few days of reduction, and you have a substance-induced. And tobacco withdrawal symptoms happen within 24 hours. 4+ symptoms within 24 hours is the criteria here. So we're back to the substance use. How do you treat it? Multimodal and multidisciplinary treatment, long-term. So we talked about some of the basic interventions that you will use. What would you say, since when we treatment plan, we think first about conceptualizing the case. So what are things you're going to want to assess for and include in your conceptualization? So you will want to assess for danger to self or others, spousal or child abuse, and legal problems. So that's could be related to confidentiality. So that's a really good place to start in terms of those very serious issues. And you also want to assess for coexisting. It could be either underlying or resulting, but other psychiatric and or medical problems. That's important. So that's 1 and 2. And then I would say that you want to also look at the family system, if it's an adolescent in particular. So those would be the things I would say are important in the conceptualization. Okay, so now you're moving into setting the goals of treatment. First, they have to recognize a substance use disorder, and that can be really similar to anorexia. That can be very difficult. Without recognizing it and without recognizing it's a problem, you won't see a lot of movement or certainly sustained. So once you have that, though, you want to establish the cessation of the substance use, which can involve inpatient detox. And sometimes people just feel like they do need to be somewhere where they're kind of separated to establish, to make that break and start recovery. So they've stopped drinking, but that's not going to be enough. There need to be new skills in place, or drinking, or whatever it might be, but they need new skills in place to sustain that. And there are problems that probably came from the disorder. So family conflict, unemployment, poverty, all sorts of things. So as a therapist, you cannot fix all of that yourself, of course. However, that's what leads us to say this really important thing to remember when it comes to substance use disorders. This is treatment that is multimodal, multidisciplinary, and long-term. It really is. You want to be thinking about groups. You want to be thinking about family. You want to be thinking about medication and the medical evaluation. You want to think about potentially inpatient treatment. So this is and it's long term. So 12-step might be for the rest of one's life. So there's that. There's 3 stages of treatment. There's the acute intervention stage, there's maintenance, and then there's the rehabilitation. You want to, if possible, have the least restrictive level of care. And that's when you go through your decision tree about whether you can do outpatient, intensive outpatient, partial hospitalization, residential, or medically managed intensive. So where do they fall? And with dual diagnoses, which is probably more common than not, you want to do sequential, so you could do sequential, parallel, and or integrated approaches. Sometimes you can't treat anything until you have them off the medication. That said, sometimes you have a client who's not at the stage where they're going through withdrawal or ready to give it up, and you need to deal with some of the relational and depression issues as much as you can to get them to a place where they can perhaps deal with the substance use, which is why motivational interviewing can be really helpful, because it's particularly geared toward increasing motivation, helping the person come to see the problem for themselves. So there is that. So what are the psychosocial interventions? So there's CBT, which is there anything on here where they don't want you to use CBT? I don't know. Behavioral interventions like contracting and stimulus control, helpful. Motivational interviewing. So that has 4 principles: empathy, develop discrepancies, roll with the resistance, and support self-efficacy. Huge, and we'll talk more about it, is relapse prevention. And that's Marlott, who says drinking is a mistake due to specific external and controllable factors. Self-help groups. In addition to AA, there's Smart Recovery and SOS. Group therapy can help reduce the shame and address the issues with others who are similar. And adjunctive treatment to promote living environment that will help prevent the relapse with families and couples can be good too. Okay, so this is a good moment to just listen up if you were tuning out. But we're going to talk about the level of care for substance use treatment, and that's something that could definitely come up as a test question. So right now we have 4 we're deciding between, which is outpatient and inpatient. So there's outpatient, there's intensive outpatient, and then you have a non-hospital residential, and then finally the most severe case would be intensive inpatient or hospitalization. How do you know where you go? So where would you put someone who requires daily monitoring but not medical supervision, and they have some resistance to quitting and a high risk for relapse? So intensive outpatient might be an appropriate place for that client. Yes, they need to be monitored daily. It's intense. So that's why you need them to be somewhere every single day. But they don't need medical supervision. What about just outpatient? This is someone who is cooperative, they're motivated, they're functioning and have support, and they don't need, of course, if anyone needs medical supervision, they need to be somewhere where they can get that. So when do you make that leap? Well, first, before we go to the hospitalization, let's go to the non-hospital residential program. This is someone who just hasn't made progress. So maybe they are going through withdrawal, but they don't have substance use to the point of the withdrawal is like delirium tremens or dangerous, but they need to go through with the withdrawal, and they need to be somewhere where there's more support because it hasn't worked so far to try it on an outpatient basis. And these are moderate problems to monitor. So when do you hospitalize? Well, first of all, obviously, if they need close medical supervision, that is essential. If there is a severe medical and psychiatric problem accompanying it, that might be important. If there's severe impairment and they're in danger, that's important. And if they have not made progress, and there's also really high resistance. So that's another example. So motivational interviewing is pretty key here for treating substance use, and it's all about readiness for change. What are the stages? Pre-contemplation, contemplation, preparation, action, and maintenance. So alcohol and Korsakoff. So alcohol Induced major neurocognitive disorder is another name for this. And you'll have interrograde and retrograde amnesia, confabulation, making up stories due to thiamine deficiency. And just note that alcohol interferes with creating memories, so this is more of a storage rather than a retrieval problem. Important fact about smoking, 75% of those who try relapse within 3 months. Or 2 months, 2 months. So we're mostly talking about withdrawal, but since cocaine might be on the test, just know that dilated pupils is one sign of intoxication. In terms of withdrawal, alcohol, within a few days of reducing alcohol, there will be agitation, hyperactivity, seizures, hallucinations, hand tremors, anxiety. For opioid withdrawal, you want to see you'll see 3 more symptoms after reduction. Dysphoria, and just think about the flu. It's like the flu: nausea, fever, muscle ache, sweating, diarrhea, insomnia. They also have dilated pupils. Then you can picture somebody who is going through tobacco withdrawal. All of a sudden they're hungry again, their appetite's not suppressed, they're irritable, they're anxious, they're distracted, they're sad. Marlatt is a cognitive behaviorist who's well known for his model of relapse prevention. Unlike AA and other abstinence-based programs, Marlatt views addiction as an overlearned habit and attempts to minimize the effects of relapses by teaching recovering addicts to view relapses as inevitable experiences, instead of viewing recovery as all or nothing, and a relapse as due to lack of motivation or as a failure. The client is assisted to view each setback as a lapse to be learned from. Part of Marlatt's model includes identifying and assisting addicts to identify the triggers for relapse, which may involve external factors, interpersonal situations, or internal states, such as thoughts, feelings, or physiological sensations. The most common relapse trigger is thought to be the client's negative emotional state. The client is then assisted to develop new skills or behaviors for dealing with triggers, like talking to a friend instead of using drugs. So Marlatt and alcohol prevent alcohol relapse, which we've talked about. The question on the test will be, who is most likely to relapse? And you just want to know that those who are in the most distress and have the most negative moods, that those are the pieces that are going to kind of cue them, since in the first place it was an attempt to deal with anxiety. Okay, now we're going to talk about neurocognitive and personality disorders. Know about delirium, and then different aspects of kind of major and mild, and then we can go into different versions. So delirium requires 2 things. The first is a disturbance in awareness, and the second is a cognitive disturbance. So the disturbance in awareness can arise in a very short period, and there's a lot of fluctuation. The cognitive disturbance means that there's memory, orientation, language, perceptual, visuospatial, that there's just this general confusion. And the treatment here is to figure out whatever was causing it. So if it's withdrawal, you need to treat whatever the cause of the delirium is. But the way of kind of handling it in the moment is to reduce the agitation involved by a really caring environment and antipsychotics. How do you tell the difference between delirium and dementia? Delirium is abrupt, dementia is prolonged. So, treating and assessing dementia. Dementia is often associated with major and mild neurocognitive disorders, and dementia has actually, major neurocognitive disorder is now subsuming the official diagnosis of dementia. That said, there are different kinds of neurocognitive disorders, and so what's a general principle in terms of how to treat and assess? Well, even though 60 to 90% of dementia cases are Alzheimer's, they aren't all. So there's a dementia rating scale, and it's comprehensive. It looks at intelligence, memory, cognitive skills, functional status, and problems. So it's like how you're thinking, what you can remember. That's certainly important, but also how are you functioning and what kinds of what is your daily living, because that really can deteriorate over time with dementia. So that dementia rating scale is one way to screen. And how do you treat? Well, there's a lot of different things you can do. It certainly depends on the cause. One thing that is frequent is support for caregivers. Here's also some other alternatives. Emotion-oriented therapy, stimulation-oriented therapy, behavioral-oriented treatment, environmental manipulation, and then in some cases SSRIs can help with the depression aspect that can be resulting from dementia. Okay, so how do we deal with delirium? We need to treat the underlying cause and reduce the associated agitation. There are a number of causes. It can be in older adults. There can be decreased cerebral reserve because of things like dementia or stroke, post-cardiotomy patients, burn patients, people in withdrawal. So there's a lot of different things that can cause it. But you want to deal with whatever that happens to be. All that said, there can be agitation with dementia, and you need to deal with that first. Antipsychotics like haloperidol can be helpful, and specifically with alcohol withdrawal, benzodiazepines can help and also stave off delirium tremens and death. Sedatives are contraindicated because they may mask the symptoms. The second thing that you can do here is environmental manipulation, and the way you do that is by really creating a very calming and caring environment. So you're friendly and you're calm, and that helps to minimize the disorientation that they're probably experiencing. So there are major and mild neurocognitive disorder, and this is about how severe it is. There's evidence of significant decline from functioning that interferes with independence and doesn't occur in the context of delirium for major neurocognitive disorder. For mild, there's modest decline in functioning, and they can still be independent even if they're compensating. The DSM-V identifies 13 different types based on their etiology. We're going to talk a little bit more about 3 different kinds, the Alzheimer's, vascular, and HIV disease types. But there can be other causes like Huntington's, Parkinson's, traumatic brain injury, etc. Okay, so we'll go a little deeper into this in a minute, but for neurocognitive disorder due to Alzheimer's, you want to look at declines in cognitive functioning and declines in ability to carry out basic daily life tasks. So when you're in the minor area, you're still able to be independent. There's a modest decline in cognitive domains, some maybe difficulty with memory, but still functioning independently. Once it's major, it's a significant decline, and it's really interfering in multiple ways. The onset with Alzheimer's disease is insidious and gradual. It's slow, it's progressive. Some days are better, some days are worse. So it can be unclear even to, caregivers, friends, family members, what's exactly happening. Because some days they seem fine, but it's progressive. There's 3 stages: stage 1, stage 2, and stage 3. Unlike vascular dementia, or neurocognitive with vascular cause, this is long and drawn out, which isn't, there can still be good in life and love and family and all of that, of course, but it's a long process. So stage 1 is the first 3 years. So there's some irritability and there's some change in mood, right? Like there's more sadness, more indifference, and there's some starting to be a difficulty with anterograde amnesia. So basically, it's hard to kind of remember, where did I put my keys, or what did I do yesterday? There's trouble forming new memories. And you might notice a little visuospatial disorientation. Stage 2 happens in the next 10 years. And that's when retrograde amnesia, the past starts to go. Mood becomes more labile, more flat, more agitated. And then you start to get things that are a little bit more representative of a kind of purely or more pure cognitive decline with aphasias, acalculias, apraxias. And then finally, 8 to 12 years when you start to see the severe case. And this is really deteriorated functioning to the point of, sometimes not able to talk, limb rigidity, incontinence. So those are the 3 stages. So what does it look like with Alzheimer's disease? Here you have a really insidious onset of symptoms and a gradual progression. There's 4, or not 4, Bella is dreaming. There are 3 stages here, starting from the first 3 years, the next 10 years, within the next 10 years, and then 8 to 12 years. The first 3 years, the hard to form new memories, and there's some visuospatial stuff and irritability. But as you get deeper into it, retrograde amnesia begins, and the mood starts to flatten, and there are language and kind of more problematic things. And then finally, once you get on the average about the 10-year mark, there is really severe deterioration that occurs to the point of incontinence and really not functioning anymore. There's a genetic component here. The early onset is associated with chromosomes 1, 14, and 21, but there is different chromosomal piece. Acetylcholine is the associated neurotransmitter, and the brain area is the medial temporal area. In particular, the hippocampus and amygdala are impacted, as you can imagine, because of the emotional issues and the memory issues. You can get this disorder if the criteria for probable Alzheimer's has been met. And 60 to 90% of people with dementia actually have Alzheimer's disease, so it's the main cause. Vascular episodes can also cause neurocognitive problems. Diagnosis, there was a past cerebral vascular disease. With this, unlike Alzheimer's, which is insidious, there is an acute onset. Well, there's 3 different ways. There's acute onset where there's partial recovery, there's stepwise decline, and then there's progressive that, it fluctuates in terms of how much concentration, memory, and psychomotor speed there is. Neurocognitive disorder due to HIV infection. The HIV is the source of the problem, and it causes subcortical area damage. There are considered to be 6 stages from 0 to 4 end stage, where you progress from normal to the point of vegetative and incontinent. Impairment of concentration, memory, there's depression and tremors here. So how do you treat neurocognitive disorder? Because this is, yes, there's a psychological aspect, but this is often really just a medical, not that they're not all medical, but there is a medical disorder happening like Alzheimer's, which is not a psychiatric disorder, but it has psychological impact. And what do? So what you're doing, what is your goal? Your goal is to help the patient attain the highest level of autonomy that they can in the least restrictive environment that they can. You want to help them manage any of the psychiatric symptoms like anxiety and depression, and provide both the patient and their family coping strategies. And that can increase the quality of life, even struggling with a neurocognitive disorder, for everyone, because this impacts the whole family. Another thing to do is to also help clarify the nature and extent of the deficits, because there can be kind of confusion around what's happening and all of that. So what are the ways in which you can do this? So support for the patient and family is really important. And one way to help the family is to help them learn to create a very stable and consistent environment with a daily routine. So some families are already like that and some just aren't. But when you have someone with neurocognitive disorder, it's really important that there's a very structured environment, and that can help with memory and cognitive deficits and allow that person to be able to maintain some independence in functioning. So you want to do that. You want to help with the medication management, just in terms of adherence and all of that kind of stuff. and help the family members know when additional help will be needed. So what are the signs that, I mean, this is maybe not a great example, but like, what are the signs of stroke? When is that happening? Or, when are they going to know that they need to give the psychiatrist a call to make sure that, like if their mom wandered off down the street and was lost and didn't know where they were, it might be a sign that things are declining and getting to a different level and need different intervention. So overall, though, you have there are 4 categories that these are all falling in. And like very clearly, the family caregiver interventions, which is both to help the family and the patient be happier and cope, but it also, it's about increasing everyone's well-being. There is the psychosocial, and we haven't talked as much about that, and we'll move into that in a moment. But there's also the environmental manipulations. This is partly the daily routines, but ways to enhance memory and increase safety. And the pharmacotherapy is potentially helpful because there are associated anxiety, depression, both as part of the disorder itself and as a result of the struggle. So SSRIs can be given for the depression, antipsychotics for some agitation. Interestingly, cholinesterase inhibitors can sometimes slow the rate of cognitive impairment. And let's talk more about the psychosocial, which include behavioral-oriented therapy, emotion-oriented reminiscence therapy, cognitive and rehab, and then stimulation therapy, which is like art and music. And of course, in terms of the referral, before we go deeper into the therapies, of course, you're going to do the medical evaluations and the psychiatric. That's probably already happened. But you also want to make sure there's neuropsych, and caregivers can have, there are support groups for caregivers that can be helpful. Structured adult daycare programs and financial counseling like Medicare can be helpful for both the patient and their family in dealing with the transition. So how do you treat neurocognitive disorder? One kind of therapy is called reminiscence therapy. And this is defined by the APA as the use of life histories, written, oral, or both, to improve psychological well-being. The therapy is often used with older people. This form of therapeutic intervention respects the life and experiences of the individual with the aim to help the patient maintain good mental health. The majority of research on reminiscence therapy has been done with the elderly community, especially those suffering from depression, although a few studies have looked at other elderly samples. So this would be sitting with someone and having them show you their photo album and tell you about their life. And lastly, we'll talk about personality disorders. 3 clusters. Cluster A are the odd and eccentric. Cluster B are the dramatic, emotional, and erratic, and cluster C is the anxious and fearful. So the mnemonic you can use to remember is we've got A, B, and C. So A is for abnormal and awkward. There's a little picture of Elmo on the slides here. B is for borderline and buzzing. So those are the dramatic, erratic types. And C is for cautious and careful. And just to note that though avoidant folks can be a little bit awkward, and it does start with an A, it is much more about being cautious and careful and anxious. So A is more the schizotypal, kind of eccentric, odd. And B, the borderline and buzzing, is your narcissism, histrionic, antisocial, etc. So let's talk about just a summary overall of all the personality disorders. So the diagnostic criteria is going to be an enduring pattern of inner experience that deviates markedly from cultural expectations. There are symptoms in 2 or more areas: cognition, so how one thinks, affect, the emotional states and experience, interpersonal functioning, it's really prominent there and obvious there, and then impulse control. What's characteristic of these disorders is that they're pervasive and inflexible. So on the CPSE, if you have an explanation of a client or a vignette where something's been chronic and you see it at home and at work and it seems like it's gone back years, especially if there's kind of an interpersonal aspect to it, like getting fired from jobs and breakups, then it's important to consider at the very least personality disorders. The onset is typically early adolescence or adulthood, and with antisocial, for example, though, it has to be before 15 that the onset happened. That said, you cannot diagnose it until after they're 18 years old. So often they will be diagnosed with oppositional, defiant, or conduct disorder beforehand. With narcissism, you'll see it also typically begins in early adulthood. And just some specifiers, you note the clusters. We talked about the clusters, so note whether it's A, B, or C, and C for your second to yourself if you can just name the types in the different clusters and what the clusters are all about. There are 3 types in A, 3 types in C, and then the middle of the sandwich, B, has 4 different types. So see if you can think of those. Paranoid and dependent aren't discussed as often as some of the other ones, but paranoid is in cluster A and dependent is in cluster C, as you can imagine, with them being very anxious. So the best treatments overall, and we'll talk a little more in particular about borderline antisocial, but just here's the key points, is that for borderline personality disorder, you want to think DBT, and in general, short-term and skills-focused therapy can help improve psychosocial functioning, among other things. Referrals that you want to think about in personality disorders, in some cases, psychiatric medication doesn't help because it's more of a personality thing, but with borderline, for example, sometimes mood stabilizers, or maybe SSRIs. There could be coexisting conditions, both as a result and tied to it. Especially because there's definitely some theories, this probably isn't on the test, and maybe don't even think of it as on the test, but there's definitely a theory that it's really, borderline is just attachment trauma. So make that referral for the evaluation. And other important referrals to make, 2 things. Self-help groups can be helpful because it's so pervasive. There needs to be really continuous care and community. It's similar to substance abuse problems and alcoholism. There, especially with something like borderline, and not for schizoid and other ones, but given the sort of more ingrained nature of it, it's important that they have support more frequently than just once a week, at least when they are kind of more in the throes of things. Inpatient hospitalizations are helpful in terms of stabilizing acute episodes, in particular with something like borderline personality disorder, which we will talk more about in a moment. Okay, so now we're going to do a very quick rundown of the 10 personality disorders and how many are in cluster A, which is, and how many are in cluster B, which is, and how many are in cluster C, and what is cluster C. So answer that for yourself. And now I'm going to begin to go through them, starting with cluster A, which, as you probably just named, is the odd and eccentric presentation, and what's your mnemonic? Abnormal and awkward. The 3 here are paranoid, schizoid, and schizotypal. So schizoid and schizotypal sound similar, easy to remember those 2, and since there's only a third, paranoid, if you can remember it exists, clearly that's going to be your more odd and eccentric one. What does that look like? This looks like a pervasive distrust and suspiciousness of others, and this tendency to interpret actions of others as deliberately demeaning, threatening, malevolent. You've probably met to some degree people of this type. Maybe they're not fully have the disorder, but in your life, people who kind of just always are attributing others to they're out to get me, at work. Like a colleague does something, sends an email with that maybe is a little bit short, and it's they're trying to get me fired, They suspect, so here you need to have, and this can be a little bit difficult to remember, but a lot of times with the personality disorders, there is 4 or 5 symptoms needed. So with paranoid, you need 4, and among those are suspecting exploitation,
People are harming them. They're preoccupied with doubts about trust. They're reluctant to confide. They're afraid people will use things against them. Benign things become threatening, grudges, perceiving attacks, counterattacks, and also you would imagine maybe believing their partner is unfaithful. I will say, when I read this one sentence that says interprets benign comments and events as demeaning or threatening, I think one way to really, as a clinician, and this is kind of my interjection, to be A, most helpful, and B, actually probably more in line with reality, is to acknowledge that there's always something little. And yes, you probably want to explore, who knows, maybe something happened in their childhood where they really couldn't trust. So a lot of the reality might be more about that, and you can help them tie it back to the original event if you have that kind of orientation. But, I think just saying, they're just interpreting benign comments as threatening, can be somewhat of countertransference on all of our parts, because it's really not fun to be around someone who's always angry and counterattacking, even when you really are coming from a pretty much benign place. They're still reading things that are somewhere deep under the surface, maybe even if it's just a 100th sliver of reality. And then, of course, they end up creating some of these things, like we all do with our expectations. So that was a lot on paranoid. Maybe it's deserving of a little more time, because I have not found it's discussed as much. So what about schizoid? Schizoid is a pattern of detachment from and indifference to social relationships. There's like a restricted range of affect. Here you also have the 4 symptoms, not enjoying closeness, being solitary, not interested in sex, little pleasure, no close friends, indifferent to praise, cold, detached, flat. Okay, and so this type, they don't really care much, right? So with avoidant, you might find they're also really super loners, but they feel longing and sensitivity and hurt when thinking about fear of rejection. With schizoid, there's much more of an indifference, and you're not going to find these people in treatment very often, because maybe you do, but this isn't actually a problem for them, even if we might have a problem with it if it's someone in our life that is a family member or someone we want more closeness with. Schizotypal. This is the type that is connected to schizophrenia, and first cousins. There's a higher chance that you'll see schizophrenia. What would you say? How would you describe it if you had only 5 words? It is a pattern of blank. Deficits in social and interpersonal functioning. I guess we should actually add more than 5 words, because that's true in a lot of the personality disorders. But what is it marked by? Reduced capacity for closeness, and then peculiarities. So the peculiarities happen kind of in all aspects of being, whether it's cognition, perception, ideation, appearance, and behavior. So these are your folks who are odd, Honestly, I think that schizotypal folks can be the most fun ever. Now, of course, if there's a lot of, maybe that's not, of course, if there's a lot of suspiciousness and paranoia, that can be problematic for relationships, but, they might have odd beliefs like telepathy and clairvoyance, so maybe that's part of why I can relate. Unusual perceptual experiences, odd thinking and speech, lack of close friends, social anxiety with paranoid features. So you can see the strong tie to schizophrenia. But I think maybe in all of these cases we should appreciate the interestingness and difference of people, and that there are good things that come along with all of this. Okay, that's a statement to unpack and discuss, so you can have that conversation after the test. So cluster B, what's the mnemonic for it? Or your own, if it's not the same. Bizarre and buzzing. So buzzing, I say, because you can sometimes have, like, with the narcissism, there's kind of like bigness, and with the histrionic, excessive emotionality. So that's kind of what I mean by buzzing. It's the only B word I could come up with. Now, borderline, you could also think borderline and buzzing, because borderline is also in here. So let's start with antisocial. If you think dramatic, emotional, and erratic, to me, I really do end up picturing borderline when I think of dramatic, emotional, and erratic. That said, if you have someone committing unlawful acts, lying, having physical assaults, you got to think physical assaults, that's erratic. Disregarding safety, irresponsibility, not remorse. So yeah, in some ways there's not the same kind of emotionality. In some ways there's a lack of emotion, but you still want to think that they're, in terms of anger and the physical fights and assaults, even if there is a flatness and a lack of empathy, there's still, you'd have to talk to an expert in antisocial, but the assaults and the kind of viciousness that can happen, there's something there that is on that emotional or repressed emotion line. And what do you want to remember in terms of age of onset and when you can diagnose it? That's really important to think about. It needs to be, there needs to be evidence of it of conduct disorder, that is, before age 15. And before you can get the diagnosis, you need to be 18 years old, which I think is very fair because it's a pretty serious diagnosis and one of those that's viewed as quite intractable. Similar to borderline, but I have another comment on that. So borderline is the next one we're going to talk about. So antisocial and borderline are the one are frequently discussed, though narcissistic is too. But borderline, antisocial you might end up seeing in prison settings. They get in trouble with the law. Borderline you might see more an inpatient with the recurrent suicidality. Whereas narcissism, perhaps we talk about it in terms of providing individual therapy because you see that, but in terms of sort of the extreme situations, there's not as often the sort of physical danger that you see with antisocial and borderline, though from different places. So what is borderline? You really want to, if you see a question or a client where you're seeing really unstable interpersonal relationships, you want to consider this diagnosis. We all have these tendencies. Every single one of these things we have in each of us, and under stress, we all have our tendencies of where we go. So don't necessarily diagnose someone as fully with the disorder because it can come with a lot of stigma. But you also do want to catch it so that you can really tailor treatment and help people the most. And we really should stop pathologizing people as much as possible in general because it undermines treatment. So borderline, there is real instability of mood, instability of interpersonal relationships, self-image, and a lot of impulsivity. And here you want to see 5 or more symptoms. So along the lines of abandonment, unstable relationships, idealizing, impulsivity, it could be with spending, sex, substance abuse, recurrent suicidal or self-mutilating behavior, emptiness, anger, and dissociation. So all of that. Some people think of borderline as attachment trauma. And in terms of onset and diagnosing, while it's viewed as very intractable, there is also evidence that says that after that you see it in the 20s and 30s, but it tends to kind of disappear or the prevalence goes down after 40. So I think there's actually a lot more hope than is given credit for. We're going to speed through the rest just for the sake of time. But histrionic. So features of histrionic, this is the one that is just about excessive emotionality and attention seeking. Yes, borderline and histrionic could look the same, but they're really not because there's a kind of shallowness to emotion. It's really about being the center of attention. Considers people closer than they are, and there's just a rapidly shifting emotions. 5 or more symptoms here. Narcissistic, 5 or more symptoms. So you see, I think, with most of the cluster B, it's 5 or more. Narcissistic, grandiosity, fantasies of greatness, belief in being special, need for admiration, entitlement, exploitative, lacking empathy, envious, arrogant. Cluster C, these are the anxious and fearful ones. And there's 3 of them. Can you name them? Okay. So OCPD, that's the obsessive compulsive. So you can think that's very anxious and fearful. That's probably a pretty easy one to think of, but there's also avoidant and dependent. Avoidant is a pattern of social inhibition, feelings of inadequacy, and hypersensitivity to negative evaluation with 4 or more symptoms. Fear of criticism, disapproval, won't get involved because they're not certain they'll be liked, restrained in intimate relationships, preoccupied with rejection, just a basic sense of inferiority and inhibition. Dependent is a pervasive and excessive need to be taken care of, and what it results in is submissive and clinging behavior. It's just hard to do much of anything without somebody else, like can't make a decision without reassurance, don't want to assume responsibility for things. They'll go along, they're terrified of losing your approval, and they'll really do much of anything to get support from others. When they're alone, they just don't feel like they're self-sufficient and will seek new relationships when one ends with fear of being alone. A little different than the borderline sense of emptiness and impulsivity, but there is still the sense of there is a sense of it will be dangerous if someone leaves. So that's a similarity, but it is different. Obsessive compulsive. This is not obsessive compulsive disorder, it's personality disorder. So this is more just, if you picture, maybe they should even give it a different name. This is really about someone who's very inflexible and can be very inefficient because there is a way they want to do things. There are details, rules, schedules. Sometimes the point of why you're doing it gets lost in the way that things are supposed to be done. There is just order, perfection, control, a drive toward that. That trumps whatever else the activity is. It's about how that activity is done in the perfect way, which then it gets in the way of actually completing things, and there tends to be more of a focus on work and a drive toward being, the perfection, moral, and difficult then to discard things and delegate. They can be stingy with money, rigid and stubborn. And what I would say here, and then I guess what I'd say here is that can lead to a lack of friendship and fun in life. Okay, so those are the personality disorders, and we are going to have a lot of fun now in talking about the treatment of personality disorders.
There are new culture-related diagnostic issues, like with schizotypal, voodoo, or antisocial is overdiagnosed with lower SES.
Okay, so in terms of the treatment for personality disorders, you want to help patients recognize the maladaptive nature of their characteristic ways of responding and provide them with skills training so they can alter their characteristic ways. There are often coexisting mental disorders, so you'll want to treat those and resolve any core psychological issues. Ultimately, in terms of improving functioning, there's definitely the aim in all of them to improve interpersonal relationships. So with paranoid personality disorder, you want to decrease the distrust and suspiciousness of others and help improve in reality testing. For schizoid, you'd want to increase the awareness and experience of emotions, since there can be a lot of cutoff, and enhance their interest in social relationships. It's not just the skills, it's also being interested in the first place. For schizotypal, these are the more odd kind of folks, and you want to increase their comfort in social relationships, sort of diminish their magical thinking and odd beliefs, and help them display fewer marked oddities in appearance and behavior. At least that's what this book says, or at least explore that with them so they have some awareness of how it may or may not impact others, and they can then make a choice about it. Antisocial, that's a hard one to treat. Decrease antisocial behavior, clearly. Increasing empathy for others is huge. And in terms of the safety of everyone else, increasing their respect for the rights of others. And finally, improving their ability to foresee the consequences of actions and make appropriate long-term plans, because there can be a lot of impulsivity and aggression
that really doesn't pay off for them in the long run. With borderline personality, you want to achieve stability in self-image and image of others and decrease the lability of mood and the impulsivity in behavior. For histrionic, you really want to help them modulate their method of expressing emotion or decreasing attention-seeking behavior. What's hard about saying this also quickly is it's like, okay, well, why do you want to do that? And that's something to explore. For narcissism, I think it's easy to see why decreasing a need for admiration could benefit them and their overall feeling of well-being, and help them achieve a balanced and less grandiose sense of or self-image, and also more empathy for others, which will help their relationships. Avoidant personality, help them decrease this is in the cluster C, more anxious, decrease their discomfort socially, and help them decrease their sensitivity to criticism and rejection, which is very tied to improving their underlying self-esteem. For dependent personality disorder, you want to increase their sense that they can rely on themselves, be independent, and that, again, relates to a sense of increased self-esteem. Now, for obsessive compulsive personality disorder, a lot of the suffering comes from this need for perfection order. So if you can increase the tolerance of it so it doesn't feel so uncomfortable, then you can also decrease the preoccupation with issues of orderliness and control, which hopefully will then boost interpersonal functioning and well-being in life.
Starting with antisocial, this can be an evolution from conduct disorder. There are three main areas of symptoms about social norms. You need to have three symptoms, and that is within social norms: deceitfulness, impulsiveness, recklessness, and just a lack of remorse. There needs to be a sign of this disregard of the rights of others before age 15, and at least 18.
Okay, so in treating antisocial personality disorder, there's three primary techniques. The first is CBT, and you're emphasizing the clear rules and consequences, helping them learn to tolerate affect, which is probably going to be more aggression than anything, and then helping to prevent relapse. Milieu therapy is also common, where there's a token economy, and these are programs that are often used when there's criminality and focus on teaching interpersonal skills. The third possibility, which is generally avoided actually, is pharmacotherapy. However, sometimes mood stabilizers and antidepressants can help.
Borderline, combination of CBT, or not combination, sorry. Borderline instability in relationships and self-image, affect, and impulsivity. So it's really about being unstable. From ages of 19 to 34 is typically first diagnosis. And actually, 75% of people no longer meet the criteria by the time they're 40. So it seems to improve with age. DBT goes hand in hand, and that can be on the test potentially. It's a combination of CBT and Rogers, and it says acceptance is necessary for change and is a multi-component therapy with group, outpatient, phone.
Okay, so what about treating borderline personality disorder? In contrast with antisocial, they're actually experiencing a lot more distress and more likely to seek help, both inpatient and outpatient. So the five things to remember, and I think the first is the easiest, which is DBT. Pharmacotherapy is also probably pretty easy to remember. So what are the other three types of psychotherapy? So you can definitely think about psychotherapy when it comes to borderline. There's trauma, attachment issues, a lot of depression that can co-occur. So there's also transference-focused, mentalization, and interpersonal, which, as you know, is associated with depression as well. So we'll talk a little bit more about transference and mentalization in a moment, but as you know, interpersonal was originally developed as a brief treatment for depression, but it's also considered effective because of the disturbed interpersonal relationships is so key with borderline. The duration, however, here is extended, and between session phone contacts are used to deal with the crises and maintain the therapeutic relationship.
Linehan's dialectical behavior therapy. Marsha Linehan's DBT is a structured outpatient therapy program for persons with borderline personality disorder. The dialectical point of view underlies the therapy, with the key dialectic being acceptance on the one hand and change on the other. The therapy is behavioral, and although the past is not ignored, the therapy focuses on present behavior and the current factors that are controlling that behavior. Therapy requires that the client agree to the following 4 conditions: to work in therapy for a specified period, typically a year, and within reason to attend all sessions. If suicidal behavior is present, to work on reducing this, to work on any behaviors that interfere with the course of therapy or therapy interfering behaviors, and to attend skills training. The primary modes of treatment in DBT include individual therapy, telephone contact, group skills training, and therapist consultation. Individual therapy, the individual therapist is the primary therapist, with the main work of therapy being carried out during these sessions. Telephone contact is used to provide the client help and support in applying skills learned between sessions and to help find ways of avoiding self-injury. Skills training is carried out in the group context, typically with someone other than the individual therapist. The 4 groups of skills focused on are core mindfulness, interpersonal effectiveness, emotion regulation, and distress tolerance skills. Therapist consultation. Therapists are required to receive DBT from each other at regular therapist consultation groups.
Okay, so transference-focused therapy is very interesting. It combines ego, psychology, object relations, and attachment theory. And this really is the perspective that views BPD as the result of poorly defined and fragmented representations of the self. So they see that as then leading to the use of very primitive defense mechanisms, and that there's this diffusion of identity. So the primary goal is to integrate these fragmented representations, and to achieve this, the therapist really focuses on the interactions between the therapist and client. And that means being in the here and the now and using the client's transferences. So the common psychoanalytic techniques of clarification, confrontation, interpretation are used. Mentalization-based therapy views borderline as a result of early trauma. That's the biggest emphasis, and says that when we have this is also psychodynamic in its background, but in attachment-based. When we have disorganized attachment, it then interferes with our ability to even develop our social and cognitive abilities, which are needed for mentalization. And mentalization is basically how we make sense of ourselves through mental processes. If you can't do that, you don't have a sense of self, and you also have disorganized attachment, so there's a lot of stress. And the therapy then focuses on how can you increase mentalization capacity. And one way of doing this is to really help the client bring emotions into the relationship. So can you name them? Can you understand them? Both in terms of past and present. Express them appropriately and understand the response others may have to you. We're also going to talk about treatments for specific populations, in particular the culturally diverse clients, whatever that really means, but yeah, not white, Anglo-Saxon Americans. And then we're going to talk about victims of intimate partner abuse, child abuse, older adults, and lesbian, gay, bisexual clients.
So in psychotherapy, there's 2 different kinds of stances that therapists can take, or way they can be. One is cultural encapsulation, and the other is cultural competence. So cultural competence, as it sounds, is a good thing. You're aware of your own culture, you've learned about the client's culture and their cultural values, and you've acquired skills and knowledge for working with people that have different languages, histories, traditions, and values. The culturally encapsulated therapist really impedes effective therapy with minority clients. And this is because the therapist makes narrow assumptions about reality, minimizes cultural variation among individuals, disregards evidence that disconfirms the superiority of the dominant culture, and resorts to technique-oriented strategies and short-term solutions, judging others according to the encapsulated therapist's self-reference criteria.
So, older adults often struggle with anxiety and depression, just given facing kind of dementia and aging and all sorts of things. It's more heterogeneous than just one-size-fits-all. But they actually do respond very well to treatment. It's just slower. So the kind of main treatments here are behavioral, cognitive, and brief psychodynamic. So interpersonal as well, it can be helpful.
And one thing that might be necessary is to address their negative attitude toward their problems. So slow the pace, and one important thing is to know that reminiscence therapy and validation therapy are both specifically developed for older adults, and to treat dementia, depression, other disorders, and have been found to be empirically supported. Okay, so let's talk about treating African American clients. In general, there is a preference for structured, time-limited, and problem-solving therapies, and ones that foster empowerment by adopting an egalitarian approach, as well as family systems that include the extended family. Boyd Franklin recommends a multi-system approach that combines structural, behavioral, and intervenes at multiple families, but it's ultimately about empowering families by directly incorporating their strength into interventions. For Hispanic, Latino American clients, to culturally adapt, you can take, there's a preference for sort of active and solution focused, so you can adapt behavioral and cognitive behavioral therapies appropriately. One way you want to adapt things is to include immediate and extended family. There is an emphasis on familismo. One named therapy is called ecostructural family therapy, and it was developed specifically for low-income ethnic minorities. It's very consistent with the Hispanic Latino culture generally, if we were to treat it like it's all one and the same, but some of the general aspects, I suppose. And it provides intensive family therapy, and also will foster relationships between the family and some agencies. So with Native Americans or American Indian, it's common for family, friends, community to participate in healing rituals together. So therapies that can do that are recommended. Specifically, you can remember network therapy, which is conducted in the individual's home, incorporates community, and it really situates the psychological problems within a whole context and social system. Perhaps we should all do more of that, to be quite honest. Okay, and so for Asian American clients, they often expect therapy to focus more on behaviors and emotions, and they're expecting more of a hierarchical model. They want the therapist to give them concrete advice, and they see them as the expert. So consequently, CBT, solution-focused, other brief, structured, goal-oriented, problem-solving approaches that focus on alleviating specific symptoms are often preferred. Because individuals from more collective cultures prioritize respect and concern of needs of others, it may be not necessary to modify treatment, so they incorporate a collectivist perspective.
So what about gay and lesbian identity development? R.R. Troyden developed a model, and it has 4 stages, starting with sensitization and moving to identity confusion, then identity assumption, and finally commitment.
Okay, so in working with victims of child abuse, the 2 therapies to know are abuse-focused cognitive behavioral therapy and then trauma-focused cognitive behavioral therapy. And the main strategies are really about educating, working both with the kids and with the parents, and there's a very cognitive, supportive, and skills-based approach underlying the education and working with all levels. Abuse-focused is short-term, and it targets the characteristics that are associated with the abuse and the context and the consequences for the kid. So it's about the kids and the families together. And then trauma-focused CBT is short-term treatment for reducing CBT and all other associated things. The core components are education, then you want to help them deal with the feelings, and since exposure has been shown to be very helpful for PTSD, there's a gradual exposure through trauma narration, and it really just tackles it from all angles with cognitive, safety skills training, parent behavioral training, joint sessions, etc. And with victims of intimate partner abuse, 4 things to remember. First of all, safety planning. So if a woman reveals, and I guess it could be a man too, it could be that they've been a victim of intimate partner violence, the first thing to do is conduct a risk assessment, and that needs to take place in private unless they request the presence of a family member or friend. If they're acute, you need to discuss the immediate options that she has. If it's
appropriate or required, you can contact the police. Sometimes it's not appropriate or required, but it sometimes is. If this is kind of an ongoing thing, the client needs to develop a safety plan and know referral resources like shelters and legal options. In terms of the individual therapy, there are a number of approaches that have been developed specifically for female victims, and they focus on, they integrate CBT, trauma, and feminist therapy. They really emphasize women's strengths. Survivor therapy is one. And groups can be helpful. Support groups can be helpful in conjunction. As couples therapy is very controversial. Generally, it's not recommended, so the chance of them being in couples therapy to be an answer on the exam is very, very, very low. And what would be some of the requirements? They say you have to have done it separate first. There can't have been violence for 5 months. The abusers accepted responsibility, and they've both also been doing treatment groups, so groups and individuals. So if you see something like that, maybe you can say yes, but very unlikely. So yeah, the intervention: self-determination, ensuring safety, empowerment, and control, assess needs and progress, consider culture. If, in terms of the couples therapy, one thing to know is that it's more appropriate when it's expressive abuse versus instrumental. So if you have someone who abuses them as a means of control rather than is losing their temper, you are talking about two different situations, and it's unlikely that it will ever be appropriate if it's a means of control. So that's the summary of that.